Yeah, sir.
Can you hear me?
Yes, sir. Yes, sir.
Okay. So, good.
Okay, sir. We started recording. You can start the session now.
Okay.
So, good afternoon, everyone. We are starting the Asha Awards paper presentations, for which the chairpersons are Dr. Anukan Mittal and Dr. Ajit Awasthi. I'd like to introduce Dr. Anukan Mittal. He is a professor and head of the psychiatry departments, Rajiv Gandhi Medical College, Kalwa. He's academic dean for Rajiv Gandhi Medical College, Kalwa. FIAMC Biomedical Ethics Center, Mumbai. He is external consultant to United Nations CISMU Asia Pacific region, and he's also past president of IAPP. Our second chairperson is Dr. Ajit Awasthi. He's a former head and professor, Department of Psychiatry, Chandigarh. He's a past president of IPS.
I think we can skip this formality and
Yes,
go
sir.
straight to the presentations.
Yes,
We are
sir.
already late, please.
Yes, sir. Yes, sir. So we'll go on to the paper presentations. I'll hand over to the Abhita.
I shifted.
Can we have Dr. Harita? Ma'am, you can share your screen.
Yes, ma'am.
I suppose they all know the rules. Hello.
So, for the benefit of the audience, if you would like to reshare
Yeah,
the,
just-
it's perfectly fine, sir.
No, but just if you can just generally read the rules, just go over the rules, how much time they have and whatever.
Alkesh?
Yes, madam.
Yeah, okay. Let us start and we'll do it at any. Yeah. They have been told what the rules are, the time limits and all that. Okay. You can start, Dr. Arita.
Good afternoon, everyone. I'll be presenting my research titled A Cross-Sectional Study of the Effect of Adverse Childhood Events in Adults with Substance Use Disorders. Adverse childhood experiences are typically defined as stressful or traumatic experiences that occur during childhood. The effects of ACEs may manifest in different forms of including emotional, psychological, and physical consequences. In India, externalizing disorders such as substance abuse contribute significantly to the global burden of disease. Greater number of ACEs experienced have been correlated with several adult physical illnesses such as diabetes, ischemic heart diseases. However, how ACEs affect drug addiction directly is much less studied, and this research aims to determine the effect of ACEs on substance use. Along with that, other objectives were to identify the type of adverse childhood events that are most likely to precipitate the substance use and to study and correlate the socio-demographic clinical factors with the adverse childhood events. This cross-sectional study was conducted using convenient sampling method with a sample size of 135 patients aged between 18 to 65 years, diagnosed with substance use disorder using DSM-5 criteria. Patients with acute unstable medical illness, comorbid severe mental illness, and ongoing abuse such as physical, sexual, or emotional abuse were excluded from the sample. The tools used were semi-structured proforma for the socio-demographic and clinical data, adverse childhood experiences international questionnaire, and alcohol, smoking, and substance involvement screening test assist. The statistics was done using SPSS along with the other tests such as Spearman correlation, t-test, and logistic regression to study the strength of relationship. Coming to the result, the demographic variables, most of the patients, that is around 58% of the patients, belong to the age group of 31 to 40 years, most being married and having an education less than primary school certificate. Majority of the patients had a non-government employment, which mainly encompasses the daily wage workers and those working in private companies on contract basis. Coming to the relationship between the assessed score and the demographic variables, I'll be focusing on the positive findings. So the total assessed score was seen more among those with having a government type of occupation, and it was more among those who were widowed or separated. Coming to the correlation of the individual substance scores with various clinical parameters and the ACE parameters. So we found that tobacco score had a positive and significant correlation with the age of onset, duration of use, child maltreatment, and family subgroup of ACE parameter. While the cannabis and stimulants use had a positive correlation with the community subgroup of ACE score. Correlation between the total assessed score and the various variables, we found that there was a significant correlation between the duration of use and the family subgroup of ACE with the total assessed score. Coming to the strength of the relationship, we found that there was a positive relationship between the family subgroup and the tobacco score of the assessed scale. So we found that the total assessed score was more among the government employees and those who were separated. This could be explained by the fact that the high financial costs of extensive substance use, especially for the illicit drugs, could be afforded by government employees. Substance use disorders are associated with family dysfunction, which increases the likelihood of marital breakdown. It may result from the preoccupation with accessing and using the substance at the cost of other activities like family life completely. We also found that there was significant relationship between the child maltreatment and family subgroup of the ACE with the tobacco score. Experiences of abuse and household dysfunction lead children and adolescents to engage in risky behaviors like smoking as a means of self-medication or as an avoidance strategy. Being exposed to multiple forms of violence within the family or positive family history increase the risk of consuming tobacco and other substances. Also, exposure to community violence increased the use of certain substances like stimulants and cannabis. Tobacco score was also positively correlated with the total ACE score. So individuals with any ACEs may be more likely to have lasting effects on their behavioral functioning, leading to poor emotional regulation, lower self-esteem, and poor psychosocial skills throughout their life phase. So these individuals were thus more likely to have substance use disorders. The limitations of the study was that ACE experiences were retrospectively recalled in adulthood and so more have subject to recall bias. The cross-sectional design of the study and the convenient sampling use may limit the generalizability of the findings beyond the sample. These are my references. Thank you.
May I see the title of the paper first, please? Title. Okay, thank you.
Hello.
Yes, sir.
The findings are very significant for the tobacco use disorder.
Yes.
So which type of the tobacco? Because tobacco is we get in different forms. So have you calculated that?
Sir, we have not exactly quantified the data because the assist measures for both chewable and smoking forms. But we found that based on our clinical parameters, semi-structured pro forma, that most of them had a chewable form of tobacco use.
Can we request that the people who ask the questions identify themselves first, please?
Yeah. I'm Dr. Bhavesh Lakrawala from Ahmedabad.
Right.
Well, I'm Dr. Avasthi. I have two questions from you, Dr. Harshita.
Yes, sir.
I somehow missed the adverse childhood events items.
Yes, sir.
I don't see any table. Am I right in saying so?
Yes, sir. Sir,
why have you not presented it?
Okay. Yes, sir. Mainly I focused on the positive findings and the correlations. That was the main objective of the study. So the four
Pardon me.
subgroups of A.
Dr. Harshita, can I interrupt you, please?
Yes,
Pardon my
yes.
pointing out, but your major objective of the study is to see the effect of the adverse childhood events on later alcohol use the substance use disorder, the development of substance use
Yes.
disorder. That was the hypothesis that you started. But in your tables and in your analysis, I do not see any address to the basic hypothesis of your paper.
Yeah. So,
Am I correct in saying so? You can refute if you so desire.
so go back to your
Yes.
slides. Go back to your slides, which show the assist scores on the various items, and then try to correlate from that. That is what.
Assist is different, but what I'm asking is, come to your instruments used, please. Earlier slide, please, Dr. Harshita. If you don't
Yes.
mind, yeah, no. The instruments used, yeah. Adverse Childhood Experiences International Questionnaire. How
Yes.
many items it has?
43 items, sir.
Where is the item analysis? Item-wise analysis.
Okay, sir, 43 items. It is distributed as physical abuse, sexual abuse, emotional abuse, physical
But I
neglect.
didn't see it in your tables, in your results.
Okay.
That's why I find.
Mostly object.
Okay.
The
Sir,
no, okay, it's okay. We don't have that much of time, so I'll have very quick questions, and you can give your answers.
Yes.
Very pointed answers. What could be the basic objection to the use of logistic regression in the kind of data that you have? You have applied
sir,
logistic regression. Am I right in saying that?
yes, yes.
So what are the conditions which need to be fulfilled for any data set for the application of the logistic regression? That's my last question to you.
Okay, sir. Sir, the data should be have a linear distribution. The data should have a linear distribution, and
Convenience sampling will give us linear distribution?
no, sir. No, sir.
Thank you very much. Others may chip in if they wish to. Otherwise, Dr. Mittal, we can go to the
Yeah,
next.
I don't think we have time. We started a little bit
Right.
late.
So we can go to the next paper. Thank you very
Thank
much,
you,
Dr.
Harita.
Harshita. It was
Yes.
a
Thank you,
treat
sir.
listening to you, and we wish you all the very best.
Thank you, sir.
Very good
Best
knowledge
wishes.
of statistics and the instrument you use. Very pleasant hearing that. So thank you. Yeah. Can we move
Thank
to the
you,
next
sir.
speaker,
Thank you.
please? Next presenter.
Thank you, Dr. Rita. We'll have Dr. Bilal Ahmed next.
Yes, ma'am.
હેલો આપણે તમે જોયું બરાબર છે?
Dr. Bhavesh, you'll have to put it off, please. Dr. Bhavesh,
Unmute कर लीजिए अपने आप को.
mute कर लीजिए. Dr. Bilal, can you please start?
Yes, sir. Good afternoon, everybody. I'm Dr. Bilal. Is my screen
welcome,
visible?
welcome. You are visible. Let me just see. Are you screen sharing already?
Yes, yes. I have started.
I mean, can anybody see his slides?
No, I
I
cannot
can't.
see his slides.
No, we cannot, Bilal.
Bilal.
Let me share again. Let me one minute, please, sir.
Please take your time, no problem.
कोई जल्दी नहीं है. Your screen has come, but you're showing your MMC credit points.
Yes, sir.
Yes, now we can see your screen here.
Yes.
Share the slide. Very good. Thank you.
Good afternoon, everyone. I'm Dr. Bilal Ahmed, lecturer, Department of Psychiatry, Government Medical College, Srinagar. I'm going to present cytokine levels in patients with bipolar disorder, a pilot study. So the outline of my presentation will be like that. It will contain an introduction, material, methods, results, then discussion, and then conclusion. So the pathophysiology of bipolar disorders is complex, as we all know. So psychosocial, biological, and genetic factors have been found to contribute to the pathophysiology of bipolar disorder. So there is an increasing evidence to suggest that immune system abnormalities and elevated levels of pro-inflammatory markers may contribute to the pathophysiology of bipolar disorder. So the aim of our study was to evaluate 3 pro-inflammatory cytokines, that is tumor necrosis factor alpha, interleukin 6, and interleukin 18 levels in manic state of bipolar disorder before treatment and 2 weeks post-treatment. This was a hospital-based prospective case control study in which 54 drug-naive patients experiencing first episode of mania as per DSM-5 criteria were included in this study in an age group of 18 to 60 years who visited outpatient services of our department. We assessed the severity using Young Mania Rating Scale, and the patients were also called on follow-up after 2 weeks of the treatment for reassessment. 50 age and gender matched controls were also included in this study who does not have any psychiatric or physical comorbidity or intake of any anti-inflammatory drug or any other medicine in a period of 1 month prior to sampling. Written and informed consent was taken from the close blood relatives of the patients and from the healthy controls. Patients with other psychiatric disorders or bipolar disorder patients other than in a manic state with other medical comorbidity or substance use were excluded, and those who did not give the consent for the study were also excluded. After collecting socio-demographic and clinical details, peripheral blood was collected from all the participants. After 2 weeks of the treatment, 30 of the 54 patients returned for follow-up and blood samples from them were taken again. The blood samples were allowed to clot for about 30 minutes, and then after they were centrifuged at 3000 rounds per minute for 10 to 15 minutes so that the serum is separated, and then that serum was stored at -80 degrees centigrade until the evaluation for those cytokines, required cytokines, was done. Prior to the assay, plasma samples were allowed to defrost at room temperature. Quantitative measurement of the required cytokines was done using appropriate ELISA kits, and the assessment was performed in accordance with the manufacturer's instructions. The statistical analysis was done using SPSS version 22 using appropriate statistical methods. Most of the patients in our study, they belonged to 21 to 30 years an age group, followed by less than 20 years. Mean age of both cases and controls was around 29 years, and there was more male preponderance in both cases and controls. Majority of our subjects were from the lower middle class. So when comparing the cytokine levels among the cases and controls, interleukin 6 levels were around 14 in manic patients in comparison to around 3 picograms per ml in controls. And this was statistically significant. The difference was statistically significant. There was no significant difference in interleukin 18 levels between the cases and controls. When we assessed the levels of tumor necrosis factor alpha in the patients, it was significantly high in comparison to the controls. Comparing these cytokines levels before and after treatment of those manic patients, interleukin 6, there was found that there was a significant drop post 2 weeks treatment in interleukin 6 levels from 14 to around 7. There was no change in interleukin-18 levels. No significant change was found in this inflammatory marker. And tumor necrosis factor alpha level is also dropped significantly from around 22 picograms per ml to 10 picograms per ml. So correlating the cytokine levels with Weimar score before and after treatment, for interleukin 6 and interleukin 18, there was no significant relation either before treatment or after treatment between the levels of these inflammatory markers and Weimar score. But there was a significant positive correlation between tumor necrosis factor alpha levels and the Weimar score. Our results are in accordance with hypothesis suggesting that immune activation may play a role in the etiology of bipolar disorders, and higher levels of tumor necrosis factor alpha and interleukin-6 suggest the role of these pro-inflammatory cytokines in pathophysiology of mania. Kim et al. In their study, they found that interleukin-6 and tumor necrosis factor alpha levels were significantly higher than healthy controls in the manic state of bipolar patients. Study done by Oberoi et al. In bipolar affective disorder, when they try to find these inflammatory markers in acutely ill patients, they found that there was a significant increase in interleukin-6 as well as tumor necrosis factor alpha in acutely ill bipolar disorder patients, both in the depressive phase as well as in the manic phase. A recent meta-analysis on this blood cytokine network alterations in psychiatric disorders, it found that acutely ill patients, whether they are in schizophrenia or bipolar disorder in manic or depressive phase or unipolar depression, all these have increased levels of these cytokines, interleukin-6, tumor necrosis factor alpha. So these findings are not specific to mania only, these are found in other psychiatric conditions as well. So in conclusion, acutely ill bipolar patients manifested increase in blood pro-inflammatory cytokines levels, and treatment of that mania led to the decrease in these cytokines. However, as we discussed, these are not specific to mania only. Other psychiatric conditions, including schizophrenia and unipolar depression, have higher levels of these pro-inflammatory cytokines. So there is a need for longitudinal data studies with uniform sampling of the patients, so that the exact role of these cytokines, what they actually play in the illness of different psychiatric conditions, so that we can come to know what exactly their role is in these disorders. Most extensive and systematic investigations are clearly warranted. The limitations of our study, it was a very small sample study. Only 3 cytokines were studied, and we did not make a comparison with euthymic bipolar patients or depressed bipolar patients. There was no comparison made with other psychiatric conditions. We are especially thankful for multidisciplinary research unit of Government Medical College, Srinagar, to cover the finances required for this experimental work. Thank you.
Thank you. Thank you, Dr. Bilal. Dr. Avasti?
Well, Dr. Bilal, thank you very much. Now, can you please tell me what was the characteristics of the controls that you chose for this study? I somehow seems to have missed that. If I can see the slide again.
So can you repeat the question, sir?
The characteristics of the controls.
Yes, sir.
Control group.
Yes, sir. So the difference between the size,
not the results and the characteristics.
Yes, is it, sir?
What comprised the control group? Basic question. What is control group?
Sir, these were the healthy controls. They were age and gender matched. They were taken from non-blood relatives of the patients. They were not blood related to the patients, and they were free from any comorbidity, medical or psychiatric comorbidity, and they should not have taken any medicine, anti-inflammatory or otherwise, prior to 1 month of.
I didn't see that slide because that's a very important thing.
Yes, sir. Yes, sir. I will.
Did I? I
Yes,
missed it. See, age and gender matched controls without any psychiatric or physical comorbidity.
ये लिखा है ना उसमें.
1 month prior to sampling was taken for the study. Thank you very much. Now I can see it, Okay.
So, Dr. Bilal,
yes, sir.
my question to you is that you mentioned tumor necrotic factor and interleukin that you measured.
Yes,
Your
sir.
slide showed there was not much difference in YMRS scores pre-treatment and post-treatment. Although clinically you
There
said
was-
that there was.
Yes, sir.
Yeah, sorry. Go on, correct me.
Yes, yes. So there was no correlation between the levels, any significant relation, positive correlation between the levels of interleukin 6 or interleukin 18 and YMR score. But for tumor necrosis factor alpha, there was a significant positive correlation. So the drop in the tumor necrosis factor alpha will drop the score of YMRS.
मतलब उल्टा है. If the YMRS decrease, that means the patient clinically improve. You are saying tumor necrotic factor, but आपका जो conclusion का last slide है,
yes,
उसमें you said that they all three are correlated. When you went to the last slide,
yes,
second
sir.
last slide.
Conclusion.
हाँ ये था ना आपका, इसके पहले वाला, ये लिखा ना आपने. Right.
Sir, there was an increase
Treatment of mania. नहीं, आपका second line है ना. Treatment of mania led to a decrease in the cytokines.
Yes, yes.
This is contrary to what your records show, no?
It led to the decrease in the treatment led to the decrease in those cytokines which were elevated, tumor necrosis factor alpha, as well as the
Only
interleukin 6.
In your study, you have said that there is no change in the interleukin 6 and interleukin 18, right?
Not, sir, there was a drop in interleukin 6, but not in interleukin 18. There was no significant difference between the cases and controls in interleukin 18. Neither was any significant change after the treatment in interleukin 18. But for interleukin 6 and tumor necrosis factor alpha, there was a significant difference between cases and controls, as well as before the.
That I got. I understood about tumor necrotic factor. Okay, I'll go back to Dr. Awasthi and.
Okay, now, Dr. Bilal, now if I get the crux of your study, what you're trying to say is that some of the cytokine are showing increased levels during the acute phase of the illness.
Yes, yes.
With treatment, which you have not specified, and it can be a confounding factor anyway. There was, decrease in the levels of some of the cytokines.
Yes.
Am I right in saying that?
Yes,
and
sir.
then what you also demonstrated that as such, the cytokine score and the YMRS, the scores, they don't positively correlate with each other. Do I get you correctly now?
For tumor necrosis factor alpha, there was a positive correlation.
There was, but not for IL-6 and IL-18. Am I right?
Yes, sir.
Yeah.
Yes.
Now, my question to you now, based on these findings, is you are a researcher. Your job is not only to see the levels increasing or decreasing, but why TNF alpha has behaved differently from IL-6 and IL-18?
So
You must have looked into the literature, what it all means.
yes.
Yeah. So why TNF alpha has behaved differently?
Sir, it has been found that tumor necrosis factor alpha is involved in activation of CRH and then ACTH and then glucoside. So that has an effect on that HPA axis as well. So somehow it might be
Mhm.
related to the pathophysiology of the bipolar
But at the
patient.
same time, there are studies which link IL-6 and IL-18 also.
So, but the studies which have shown its effect on HP axis is mostly for tumor necrosis factor alpha.
Okay. My last question to you.
So,
How will you carry forward from here? Because you said this is a pilot study.
yes, sir.
So my part A and B of the question, why do you call this a pilot study? And if it is a pilot study, what you intend to do in future?
So because this study will require a huge financial support for the research to be carried out on a larger extent. So we initially need a pilot study to see whether there are any scope of doing those investigations further or not, to see whether there are any changes in these cytokines or not. So our study found that there were changes in the pro-inflammatory cytokines, interleukin-6 and tumor necrosis factor alpha before treatment, as well as when compared to the
I get it. So what from here, where do you go? Supposing you have got all the resources.
Yes, sir. We will systematically study, we will compare between bipolar depression, bipolar patients in euthymia, and bipolar patients in mania.
Well, thank you very much. I thought you will increase the number of pro-inflammatory cytokines to see whether there are others who are presenting some interesting.
Covering the whole gamut, yeah.
Yeah, that's right. Thank you very much. Nevertheless, I think it's an interesting study, and we wish you all the best, unless Dr. Mittal has some question or to ask or something.
No.
Thank you,
Thank you very much. Well done. Good study.
Thank you.
Yeah, thank you, Dr. Bilal.
Can I have one question? Dr.
Yes,
Bhavesh,
please. Please identify.
So what was the cost of this study? It was though sponsored study.
So we were not directly involved, so I don't have the knowledge of that. So it was the medical research unit of the medical college which provided the financial. We only gave the samples to the biochemistry department, and then they provided us that assessment.
Okay.
Okay. Thank you very much. I think we'll have to go on to the next one, please. Dr. Bhavesh, thank you.
Okay. Dr. Mittal, do we go
Amita,
to the
can we
last
have the
presenter
third
now?
presenter? Yeah, third presenter.
Thank you, Dr.
Thank you,
Bilal.
Dr.
Thank you, sir. Thank you, sir. Thank you.
Thank you, Dr.
Uh,
Bilal.
Thank you, sir.
Next, can we have Dr. Gulesh Suthar?
Yes, ma'am.
So you can share your screen.
Dr. Gulesh.
Yes, sir. Good afternoon, respected chairperson and everyone present. Myself, Dr. Gulesh. I'm here to present my study, adjunctive high frequency deep TMS for treatment of negative symptom in schizophrenia, a proof of concept SMR study. Our study was conducted at KF Mani Center for Cognitive Neurosciences, Central Institute of Psychiatry, Ranchi. Negative symptoms of schizophrenia are disabling as they affect the quality of life and level of functioning for the patient and respond inadequate to available antipsychotic treatments. Negative symptoms are also associated with the altered functioning of several cerebral regions, such as insular cortex, represented by ACC and MPPFC, as provided in various literature. However, the newer non-invasive brain stimulation offer a novel approach in treatment of negative symptoms, and recent meta-analysis reported a small but significant effect size supporting the efficacy of this modality in treatment of negative symptoms. Deep TMS include all the benefits of conventional TMS, with advantage of stimulating more deeper structure targets with less superficial distribution of electric field, as shown in this figure, that the H7 coil that was used in our study can stimulate a 4-time deeper structure as compared to the figure of 8 coil that encompasses more 10 to 12 times more stimulation of more number of neurons. The H7 deep TMS coils were specifically developed to target the bilateral anterior cingulate cortex and medial prefrontal cortex, as shown in this figure, that the area stimulated by H7 coil. The utility of MRS in schizophrenia, the HMR study of N-acetyl aspartate complement the finding of structural imaging and neuropathological studies of schizophrenia. The reduction in NA is present from the onset of clinical overt illness, and there was very little evidence to suggest that this attribution can be ever attributed to the treatment by antipsychotic medication. The aims and objective of our study to explore the efficacy of high-frequency deep TMS from improving negative symptom in schizophrenia as measured by change in various scales and neurometabolite level measured by HMRS. The ethical clearance for the study was taken from Institute Ethical Committee of CIP, and the trial was registered as CTRI with CTI register number as provided. In patients who were meeting the inclusion criteria were chosen by purposive sampling. Written and informed consent were taken from the patient, and their various demographic and clinical details were collected. At baseline, SANS, PANSS, CGIS, and CDSS scores were applied, and MRS were done. Patient was randomly assigned to active or sham stimulation by envelope randomization techniques, and both the rater and patients were blinded. Active or sham deep TMS stimulation was given for 10 days, that is 5 days a week over the course of 2 weeks, and SANS, PANSS, CGI, CDSS applied at the end of 2 weeks, and after a gap of 4 weeks, that's 6 weeks, and post-MRS was done after 2 weeks. The deep TMS protocol were delivered at 10 Hz with train duration of 3 seconds at 100% of RMT with an interval of 20 seconds, where a total number of 1200 pulses were given per session, and a total number of 12,000 pulses were given per patient in our treatment protocol. The inclusion criteria were diagnosis of schizophrenia using TCR ICD-10. The age range was kept between 18 to 60 years of either sex. Illness duration was kept more than 2 years. PANSS negative symptom score was kept at more than 15. PANSS score at least more than 20. CDS score should be less than 7. Right-handed individual for uniformity, and patient giving written informed consent. The exclusion criteria was presence of any other comorbid neurological or psychiatric disorders, patient with other comorbid substance use except the use of nicotine and caffeine, patient having any metabolic implant or part in body that makes them incompatible for the MRI, and subject who has received any form of neurostimulation such as ECT in past 6 months. This is the minimal reporting standards of the MRS data. We used the Philips made Ingenia 3 Tesla MRI coil with a 16-channel head coil. Our volume of interest for ACC and MPPFC with a volume VO5 size of 15 centimeter cube. We used the Tarquin software for analysis of various neurometals, that was TNNA, glutamate, glutamine, and GABA. This was a sample spectrum got from after the Tarquin assessment. The statistical analysis was done using SPSS 25.0. This is the table of results showing the baseline characteristics of both active and sham group in terms of age, years of education, age of onset, duration of illness, and antipsychotic doses in terms of CPZ equivalent. And there was no significant difference in all these domains in respect to age, education, duration of illness, and antipsychotic illness in both the groups. This is the table showing the change in symptom severity in negative subdomain of PANSS, SANS, and CGI over the course of 2 weeks and 6 weeks in both active and sham group, and there was significant improvement was seen in the negative symptom of schizophrenia after active deep TMS, as shown by mean SANS score reduction of active group as compared to sham group, and also a smaller decrease was seen in the negative syndrome subtype of the PANSS. This is the graphical representation of the same. This is the table showing the effect of deep TMS across active and sham group in comparison of GABA, glutamate, glutamine, and TNNA in bilateral MPFFC, and there was no significant change in the level of GABA, glutamate, glutamine, or TNA noted in bilateral MPFFC. This is the similar table showing the change in GABA, glutamate, glutamine, and TNNA in the ACC, and there was a significant difference noted in the level of TNNA in active group as compared to the sham group, where the mean TNA level was increased in active significantly as compared to the sham group. Concluding the result, 43 of total patients completed the study. Both active and sham groups saw an improvement over the course of time of treatment, but however, active group showed significant improvement in negative symptoms when it was compared to the sham group. On MRS, there was a significant increase in TNN level in ACC in active group as compared to the sham. The side effect that was observed after deep TMS was scalp discomfort that was mild to moderate in intensity, headache that was mild and short lasting. However, there was no major side effect like seizure that was reported with our stimulation. Coming to discussion, ours is the first study that investigates the effect of high-frequency deep TMS using H7 coil as add-on treatment for negative symptom schizophrenia on both clinical observation and neurometabolite level using HMRS, and we found favorable effect. Though the result yielded significant benefit in negative symptom, the overall change in negative symptom was only modest and should be assessed with caution. However, the studies using conventional TMS often shows conflicting results. Thus, an ideal approach to operationalize these newer neurostimulation techniques are being development, and DTMS is one such candidate that can enhance the effect of conventional TMS by stimulating deeper cortical and subcortical studies. There was also a significant increase in TNA level in active group in ACC as compared to sham group in our study with an effect rate of 0.098. However, in a similar study with the RTMS in bipolar depressive disorder, there was increase in the NNA level that complement our findings. The strength of our study, it was a randomized, rater-blinded, sham-controlled study. We used a high-frequency deep TMS protocol in negative symptom of schizophrenia, and we used HMRS to assess change in underlying metabolite level. The limitation was it was a small sample size, and thus our results should be assessed with cautiously and cannot be generalized to the population. The research implication of our study that schizophrenia still remains in negative symptoms of schizophrenia still remains an unmet clinical needs, and modalities such as deep TMS can fulfill that gap. The potential advantage that we provided data for the tolerability and safety of deep TMS in negative symptoms of schizophrenia, and we provided a short treatment protocol for the same. However, the further research can be done to replicate our study with larger sample size and with novel protocols such as theta burst or maybe for longer duration, and we can develop some measures to identify the preferential responder for such interventions. These are my major references. Thank you.
Thank you. Thank you very much. It was a very eye-opening presentation, and I would like Dr. Awasthi to lead.
Okay.
Please,
well, Dr. Gulesh,
yes, sir.
There are 2 or 3 very central issues to this study.
Yes, sir.
I don't want to keep you guessing on that. The one is the treatment which the subjects were receiving. When I say treatment, it's not only the TMS, but also any pharmacological treatment, or whether they were drug-naive patients, whether they were patients in which a washout had been done, whether they were receiving treatment along with the TMS. Then where are the treatment details between the active and sham group? And the second is, I would like you to respond to that.
Yes.
And the second question which I have is that who was giving the TMS, who was randomizing the patients to the sham and the active TMS treatment, and who was assessing them? I mean, the blindedness of the ratings.
Sir, coming to the first
Please
question.
answer these 2 questions.
Yes, sir. So coming to the first question, all the patients were on a stable dose of antipsychotic, and we calculated the chlorpromazine equivalent for all the patients that is presented in the set table, and no treatment change were made in past 6 weeks or during the course of treatment for these patients.
Okay.
And the CPZ equivalent was, there was
It is not just CPZ equivalents, my dear, because we have different kind of psychopharmacological agents who may have differential effect on the negative symptoms.
Yes, sir. So we have mostly kept the patient on antipsychotics only and on a stable dose for 6 weeks, sir.
But what sir is asking, which ones?
Which ones?
Sir,
because there are certain
Somebody and trifluperazine.
Yes,
sir. Right.
So that we have records for individual patient, but we haven't.
That should have been taken into account, isn't so?
Yes, sir. But we
Would
haven't
you
analyzed
agree
that.
with that? I'm just suggesting. I'm not criticizing your work.
No, sir. Actually, for that measure, we avoided patient with clozapine, as clozapine is
but that is not shown in the results or in your selection of subjects. That
yes,
you avoided, you excluded patients at clozapine.
Yeah, could have used that as an exclusion criteria.
Right?
Yes, sir.
Okay. Anyway, next.
And
my second question.
Sir, second question, the patient was randomly assigned as there was an opaque code envelope opened before the selection of each patient, suggesting the patient should go on active or sham group. The rating was done by the treating JR itself, who was unaware of the treatment procedure, and I myself given the TMS treatment to all the patients.
So you provided the intervention.
Yes, sir.
And the clinical assessment has been done by the JRs.
Yes, sir.
How reliable is that?
Sir,
Research study of this nature.
Yes, sir. I didn't had any other options. I didn't.
That's okay. I understand your practical limitations.
Yes, sir. So the reliability can vary from person to person, but the
that's
change
Maybe
is
the point you made is you call it a double blind. You
So-
mentioned that it was double blind as a
rater and patients were blinded, sir.
but वो rater का blinding कितना था ना वही पूछ रहे हैं.
So the raters weren't aware of the that their patient is receiving active or sham treatment. They weren't aware.
Okay.
My last question to you, because we don't want to be unfair to you, we don't want to ask too many questions, because your study is very interesting. That's why I find it rather keen to ask some of the questions. Your area of interest was ACC and MPFC.
Yes, sir.
Am I right?
Yes, sir.
Okay. Could you have chosen some other area of interest for negative symptoms?
Sir, I could have chosen other areas. Even
Which one?
DLPFC is one area. Even OFC is one area. But the H7 coil that we use is specifically designed for these two areas only, sir. So
that's a limitation of
that's
your
a limitation
of your
because negative symptoms, dorsolateral prefrontal cortex becomes equally or more important than MLF.
But sir, there are studies they use the protocols for the DLPFC. So ours is the first study that targeted these.
That's okay. It's okay. Maybe you can use it as an exploratory study rather than definitely.
Maybe you can combine the data from these two studies. The point is that the DLFFC was something that give a more.
Sir, your voice is not audible.
My question to you is, how much does a session generally? I mean, obviously, you work in a super special center of excellence. How much would a session of this type cost in private?
Sir, there are few private setups in India that have this facility, and they are costing from 1,500 to 2,500 per session.
Per session. And how many sessions would a patient have to take to kind of reach a level of significant effect?
Sir, in our protocol, the protocol that I received from various meta-analysis, the minimum number of stimulation required is 10, but a higher number of stimulation and higher number of sessions can further enhance the study. So 10 to 20 is an ideal number.
We're talking of anything from 15,000 to 30,000.
Yes, that's
right. Okay. Okay. Anybody in the audience has any questions?
Yes, sir.
Yeah.
Can I ask a question?
Yeah, please, ma'am.
You mentioned that your sampling is purposive sampling. Are you justified in applying t-test?
Ma'am,
Do you understand what I'm saying?
Yes, ma'am, the parametric test, but ma'am, the sample, the catchment area is like uniformly distributed. So the purposive sample, we took the patient from inpatient, but every patient coming from a catchment area have an equal chances of getting selected. So in that way, but yeah, it was one of the.
No, ask madam what she means by saying, do you have a reason to, what is she trying to ask you? Ask for clarification. Na? Aapki samajh mein nahi aaya.
Now, he seems to have got the point. He has got the point. Okay. Although catchment area is not a proper justification, but you have got the point. Good. That's okay. Dr. Indu, would you like to ask another question?
Comment.
No, sir.
Would you like to comment?
You could have gone for, since you said See, if they had equal sampling, equal chance of being sampled, you could have mentioned probability sampling. In the clinical setting, mostly it is consecutive sampling where that works. So that would have been better.
Good.
Any
Point well taken.
comments, Dr. Indu, on the findings?
No, sir. Thank you.
Okay. Anybody else has any?
Dr. Bhavesh probably want to ask something.
Sir, I would like to ask that you have chosen control and active, means sham treatment.
Yes, sir.
So you are already knowing that in the sham treatment, patient is not going to improve. So rather than choosing TMS, you can choose another option, RTMS. Why you have not chosen that? The comparison between RTMS and DTMS.
Sir, for the various reasons, for first, I wanted to know the efficacy of active deep TMS as compared to the same deep TMS. Again, sir, there is debate and there are various studies that indicate that the deep TMS, the neuromodulation procedure itself have a very huge placebo effect. So I wanted to rule out that placebo effect, and that's why I kept the active and sham group rather than comparing it with some other modalities.
Okay, thank you very much.
Okay.
I think that's enough. Good.
Thank you.
Thank you very much, Dr.
And-
Gulli.
Thank you. William.
Thank you, sir.
Handing over to you back, Rakshita.
Sorry,
Hello.
sir, I didn't get that.
Handing over back to you. We finished with the presentation.
Thank you, sir. Dr. Alkesh will take over.
Yeah, thank you, sir. Thank you, Anuka Mittal, sir. Thank you, Aditya, sir. It was very nice session. We'll move forward now.
Okay. So thank you, Dr. Ajit Awasthi, and
Thank you,
thank
sir.
all the presenters.
Thank you, sir.
Thanks.
Dr. Mittal,
Hanji.
would you please call me just now and speak to me on telephone?
Yes, sir.
Yeah, thank you.
Yes, sir.
So our next session is dissociative disorders, neural correlates and management. And the speaker is Dr. Malay Davai. For this, we have two chairpersons, Dr. Sunil Mittal and Dr. Aarti Bail. Regarding Dr. Sunil Mittal, he is a founder and chairman for Cosmos Institute of Mental Health and Behavioral Sciences, General Secretary, Caring Foundation, Vice President for World Federation for Mental Health, current President for Indian Association of Biological Psychiatry, expert member on various committees of government, multilateral and non-government agencies on clinical research and policy makers at national and international level. He is a co-founder and past president for Indian Association of Private Psychiatrists, served on various committees of professional bodies, including Indian Psychiatric Society, over 39 years of clinical research and teaching work. He's a PI of over 30 major studies funded by DST, UNDCP, UNODC, ILO, Government of India, Government of Delhi, and other agencies. His areas of work include cognitive science, neuromodulation, addiction, depression, bipolar disorders, OCD, innovative models of service delivery, mental health policy and advocacy, medical technology, and AI. Conducted or presented more than 600 CME workshops and lectures, has received numerous awards, engaged with print and electronic media, theatre, and mainstream Indian cinema. He's a motivational speaker, writer, award-winning photographer, plays the violin, has been a high altitude trekker, and is now an avid traveler. Our second chairperson is Dr. Aarti Bail. She's a consultant psychiatrist at Apollo BGS Hospitals, Mysore since 2004. She has done MBBS from Thanjavur Medical College. She has done MD Psychiatry from KMC Manipal. She has done PGDMLE from NLSIU Bangalore. Previously worked as assistant professor in Department of Psychiatry at KMC Manipal for 2 years. Her special interest is mental disorders in women, OCD, medical legal aspects of psychiatry. I welcome both the chairpersons and I'll request Dr. Sunil Mittal to introduce our speaker and Dr. Aarti Bail to introduce the topic.
So you're on mute, sir.
Sir, you're on mute. Yeah.
Am I audible now?
Yes, sir.
Good afternoon, friends. So this is an important session, and we have a very eminent speaker. If I may have his introductory slide, I can't see it on my screen. It'll
Sir,
help.
it's displayed, sir.
It's there, sir.
Well, how come I can't see it? One moment. There.
Yeah.
Right. So Dr. Malay Dave actually needs no introduction to IABP members and to all the other audience who are going to be joining in or have linked in, for that matter, for anybody in Indian psychiatry. And this is such a theme, this is such a topic on which we couldn't have got a better speaker than him, because it links so many dots. This topic is not purely, going into cellular mechanism and etc., but it links so many dots, and you require a gestalt. You require somebody who understands biological psychiatry and other aspects of psychiatry in a broad manner. And so Dr. Malay Dave, who's a consultant psychiatrist in Mumbai, he's got 26 years plus of experience. He's a very well-known clinician and speaker. His area of interest is neuroscience and genetics. So you can see, speaking on something which we conventionally were trained to believe was functional and things like that, and these areas of work are neuroscience and genetics. And he's going to speak to us on this today. Then the Honorary President of Bombay Psychiatric Society in 2016 to 17. He has been a member of the IPS Undergraduate Education Subcommittee. Currently, he's a member 23-24, received various awards and honors, notably the Bombay Psychiatric Society Silver Jubilee Prize, which is a coveted prize at ANCIABP Bhubaneswar in 1999, and Dr. Anil V. Shah Best Paper Award at the 29th ASIPS Best Zone Branch, Mumbai in 1998. So we have a much awarded, very respected speaker who understands so many things. And having said that, now over to my co-chairperson to introduce the topic. So
Thank you. Yeah. Thank you. Am I audible?
Yes,
Yes, ma'am.
Okay. Thank you. So I would first like to thank the organizers for having me here, and it's an honor to chair this session by Dr. Malay Dave for something which is probably so close to his own heart. We know that dissociative disorders have, varied presentations. And when they have these varied presentations, obviously, we need to look at different parts of the brain, what is affecting which part and why it is affecting so. When we look at it that way, we would want to actually translate all of that into the management as well. And I'm sure Dr. Malay is going to do justice to each of it. So over to you, Dr. Malay, for the presentation. Thank you.
Thank you so much, chairpersons, for those kind words. And thank you, IABP, for inviting me here today to speak on dissociative disorders. I'll share my screen. Is it visible? Is it okay? So is it?
Yes, sir. Yes, sir.
Yeah, and I'm heard clearly?
Yes, sir.
Okay. So what I'm going to do is, kind of give a brief overview of how we understand dissociative disorders in terms of brain processes. And let's see if this understanding helps us to translate what we know into management strategies. So we are going to talk about neural correlates in management of dissociative disorders. Right. So let's begin with what an emotion means. So what we have traditionally understood and which we all keep continuing to understand is that an emotion is an affective experience, as in how I feel about something, as in how when somebody talks something, what are my views, how do I like that person or not, and things like that. But not only emotion is an affective experience, but basically it is a kind of a response to environmental events at a very basic level, even before I understand or give it a label of like, not like, happy, sad, angry. So how something affects me is an emotion, regardless of whether the cortex, that's the cerebral cortex, brings it to full reportable experience or not. Meaning whether I am able to give it a label or not, whether I am able to clearly understand or not, and whether I am able to express it in terms of words. All those are cortical expressions or cortical assessments of an affective experience. So there are some basic emotions that we know are there. That is seeking, fear, rage, lust, care, panic, grief, play, and shame. Now, each of these basic experiences or basic emotional experiences have got certain definitions or meanings. Seeking would mean I expect something, I am driven to find something, motivation in general. So the words that would describe emotion of seeking are these. So for fear, it's anxiety, dread, flight. For rage, it is anger, attack, fight. Lust is sexual excitement. Care is nurturance. Panic and grief are sadness and acute separation distress. Play is social joy, an opportunity to exercise and experience with all emotional systems. And shame, which is visceral pain, yes, pain, a defensive response, that is to hide, along with sympathetic activation. So the words that I'm using here to describe these different kinds of things are basically cortical labels that are given to something that I'm experiencing. But these seem to be basic emotions. However, emotions also seem to be happening or we experience in terms of a hierarchy. The very basic being seeking, that is motivation, and then it is care. I seek care. If I don't get care or nurturance, then I become angry. When I become very angry, there might be an expression of rage in terms of anger, attack, fight, which comes as a result of fear. And then it leads to collapse, despair, immobilization, death if the hierarchy continues. Now, when we talk of emotions, we need to straight away get into what emotional processes are, how they happen, and how actually they get translated into something called as dissociation. So basically a diagram of a cut section of the brain. Basically, this is the temporal lobes. So this is the hippocampus. This is the amygdala. This is the thalamus. The thalamus would be here, lentiform nuclei, right? Body of the head, tail and body of the caudate nucleus, and so on. So the point of this diagram is we need to understand that there is something called as the amygdala here. And what does this amygdala do? Amygdala is the central hub of fear processing. It gives us an appraisal for danger, safety, and familiarity in approach avoidance situations. Meaning, if there is anything new that I am encountering, it is going to signal danger or safety, and whether I am familiar or whether the situation is familiar to me or new to me. So the first thing that happens is, in a given situation, amygdala processing starts. Now, one of the most important things that we need to understand about amygdala and remember about amygdala is that it is fully developed by the 8th month of gestation, meaning even before we are born, amygdala is fully developed and we are born with a fully developed amygdala. The only thing that happens with the amygdala over years in terms of brain development is its connectivity and the influence of higher structures, higher brain structures that are present on the amygdala. So we are born with a fully functioning amygdala. Now, at the same time, which I have not, what I have not mentioned here is that along with this, I mean, if you look at the diagram here, there is this hippocampus here. So this is amygdala, this is the hippocampus. And what is hippocampus's role? It is to encode memories, right? But it is not developed as much at birth as the amygdala, and it actually takes a long time for it to develop before it functions like an adult hippocampus. So during the first few years of life, dependence on caretakers is necessary for external modulation of the amygdala. Means as a child who is uncomfortable, new, wants something, cannot do anything, will depend on the caretakers for soothing, the emotions here, nurturance, seeking, everything. And when that happens, the amygdala quietens. So an external modulation, this is healthy, of amygdala happens in the first few years of life because of the caregivers. And what does amygdala do? It connects emotional value to the object based on both instincts that we saw here, familiar, unfamiliar, danger, safe. It learns this and translates these appraisals into bodily states. So when something like this is happening, a new situation, my amygdala would kind of flag it as not safe and it's unfamiliar, and then it will start translating this signal into bodily states. And also at the same time, it enhances hippocampal processing of emotional memory. So now I'm encountering something new, something is happening in my body. This is to be recorded and kept for future reference. This is how new learning happens. Stimulation of norepinephrine and glucocorticoids, right? So something like this. Amygdala, so it receives information from the thalamus. Thalamus has received information through all sensory systems apart from the visual systems and olfactory systems, right? And it relays it to the amygdala, also receives input from the hippocampus, that is the past experiences, and also the analyzed experience from the cerebral cortex. Now, everything is fast except this, because this is slow to develop, slow to kind of consolidate, and slow to act. But once amygdala is sufficiently stimulated, it leads to behavioral, autonomic, and emotional responses. And the amygdala is also connected to various other small nuclei in the midbrain. And then what does the full expression happen like? Increased respiration, norepinephrine release, sympathetic activation, freezing responses, startle reflexes, ACTH, fearful expression. So the whole gamut of, let's say, an anxious or a fearful response happens when the amygdala is stimulated. Not only the anxiety and fear as in experiencing, but even the physiological aspects of that emotion are also governed by amygdala stimulation. So that was about amygdala. Now we need to look a little bit at other structures. And what are these structures? We'll just name them here. Superior colliculi, that is the tegmentum. Okay, this is the brainstem locus ceruleus. Periaqueductal gray. Okay, just we'll remember these names and see how these are involved in emotional processing and abnormalities that would probably lead to dissociation. So what is this tegmentum? So that is basically this part. The tegmentum is this part. So what is the role of tegmentum? The reflex pathways, including relay of inhibitory signals to the thalamus for the prevention of unwanted body movement. So this tegmentum, basically consists of rostral part, that is the upper part of the reticular formation. So basically deals with consciousness and awareness. Several nuclei which coordinate eye movements. Red nucleus which coordinates motor activity. Substantia nigra, which is dopaminergic and associated with reward and movement. Ventral tegmental area, so basically motivational salience, again dopaminergic and associated with learning and positively balanced emotions. So VTA enhances motivation and positive valence emotions, whereas amygdala is fear associated learning. So these two work differently. So anything that is perceived as fearful, amygdala will trigger. And if anything is positive, I like this, I like that, VTA gets activated. And then we have the periaqueductal gray matter around the fourth ventricle. So what does it do? Analgesia, defensive responses, reproductive behavior, maternal behavior, play and joy. A lot of complicated behaviors are governed by the periaqueductal gray. It has two parts, the lateral dorsal, which activates the sympathetic nervous system, and ventrolateral, which activates the parasympathetic nervous system. Now it's not so simple as black and white that when one area is stimulated, this happens. It's a complicated thing, but the overall output is sympathetic, and the overall output here is parasympathetic. Then we look at the other parts, which are the colliculi, superior and inferior. So let's go back to the diagram. These are the colliculi. So we looked here first, the tegmentum, and here now we are looking at the colliculi, or the tectum, or corpora quadrigemina. There are two superior and two inferior. The inferior colliculi are important for processing auditory input. They are connected to the projections from the auditory nerve. Superior colliculi actually integrates visual information with other somatosensory, auditory, and olfactory signals. So it gives a kind of a complete picture, a complete sensory picture, which is relayed to the higher centers via the thalamus. So the collicular integration of sensory input with other information from the body in conjunction with basic affective responses that we saw that the periaqueductal gray does, provides a basic sensory motor map that this is exactly what is happening. And now as an organism, the brain has to do something so that the organism survives. It could be survival from dying, or basically surviving that situation. Then we go to a little bit higher up, which is the midbrain. So what does the midbrain do? It integrates a single response to widespread activation of the cerebral cortex. So the first 2 or 3 areas, that is the amygdala, then we looked at the tegmentum, then we looked at the collicular, superior as well as inferior, and we looked at the periaqueductal gray. So this sets the tone. Now this has to go to higher centers for analysis, assessment. This is okay, that is not okay. This needs to be done, that needs to be done. What I am feeling is anxiety, what I am feeling is depression, for all that label kind of thing, so that that experience is given a proper name and stored properly. The midbrain acts as a conduit. So from the midbrain, all this information is relayed to cerebral cortex, other maybe basal ganglia, okay? And from there, again, when we have responses coming down to the superior colliculi, I said, integrates visual with auditory and other information. So the information that is coming from cortex gives us the decision about gaze and attention, where to look at, how much to look at, and focus on something. Now, under normal circumstances, from the brain to the colliculi, there are multiple pathways. So the top-down processing, that is the information that is coming from the cerebral cortex to the colliculi, is too much, and it is actually slow in being processed. So under threat conditions, all this is bypassed. All this is bypassed. So whatever that complete response is developed, let's say by amygdala, the tegmentum, and periaqueductal gray, is free to act. So under threat conditions, collicular dominance is important for rapid and effective responding. Then this thing doesn't come into the picture. No thinking, nothing doing, no analysis, just react. And the midbrain also transmits impulses to the cerebellum and spinal cords to orient the body in time, space, posture. So what is the role of cerebral cortex in all these things? To make an individual aware. So that is mediate body awareness of what is happening, where it is happening, what is the activation, what I am feeling, what it can be, that kind of thing. So mainly awareness and labeling of the emotional experience, right? So to kind of summarize, generation of effective and defensive responses. So all those lower areas, midbrain, periaqueductal gray, and hypothalamus. Top-down regulation is the prefrontal cortex and the anterior cingulate cortex. Prefrontal is the decision-making, analyzing decision-making. This anterior cingulate cortex will determine the mood state, it will determine the motivational status, go, no-go, that kind of thing. For a traumatic event, there is a rapid interchange between prefrontal cortex and the midbrain. Okay. So the cortex exerts a dominant influence when the threat is distant, means when we are safe, then we can take all the time to think about, analyze, learn. But the midbrain assumes control when the threat is close and immediate. So it's easier to engage in a logical risk-benefit analysis when not already in the clutches of a predator or a perpetrator. Whatever we have learned, again, is stored with the help of amygdala, because amygdala gives it a value. It's bad, it is worse, it is deadly, it is going to kill you. And that thing gets stored in the hippocampus as a memory. And the areas of medial prefrontal and singular cortices, projections to the periaqueductal gray and hypothalamus, and projections to the limbic areas. So everything is activated to allow a rapid recruitment of learned experiences in further responses. So this cycle keeps going on and on. That is why we keep learning all the time. But coming back to that first thing about amygdala, which I mentioned, that we have an amygdala which is almost completely adult in functioning when we are born. So what happens that at that time, if there were very difficult situations or very life-threatening or anxiety-provoking situations, let's say traumatic childhood events or adverse childhood events, at that time, only the amygdala being fully operational, okay, will code everything as anxiety-provoking or threat-provoking without the whole machinery being in place. So there is not much of cortical assessment. There is hardly any cortical labeling. A lot of things are happening downstream because that midbrain kind of takes over. So all those automatic responses are in place. And at that point in time, whatever is stored as an emotional memory without a lot of verbal content. Means there are no words. The experience is very, very how would you say, less defined verbally. So when a child is growing up and we ask the child, if the child is able to speak about difficulties that the child is experiencing, the child will not be able to give a verbal record. Secondly, these things will keep moving around. So something else happening, it is already the amygdala memory, or let's say the amygdala labeling of any experience is always anxiety provoking. So more often than not, any difficulty, even though if it's a little bit, is encountered by a child, this will tend to provoke a large scale anxious response. So, and everything keeps on getting coded as memory over and over and over again. So for a child, the child experiences the distress completely, but the child is able to express the distress hardly so. So it's very difficult to get a hang of things because of memory encoding that happens like this. So what happens in dissociation? So when we look at dissociation, there are different terms biologically. One is something called as a neurochemical dissociation. So it's a peritraumatic response to overwhelming affect, means what I'm experiencing right now. So when I'm talking of affect, okay, it's what the situation is, how the situation is assessed even before the label is given. That's what I mentioned in my first slide. What is an emotion? It's not only happy, sad, but it also means the effect that the environment or the environmental situation has on me. And in this neurochemical dissociation, there is an overactivity of endogenous cannabinoids and opioids. So this is amongst the first responses that happen when there is a exposure to a life-threatening, threatening, or a traumatic event. That is called as neurochemical dissociation. Why? Because whatever the responses are kind of extreme and not in keeping in line, and they are coming acutely in a short frame of time. So this is the first step, that is neurochemical dissociation. And that leads to a second step called as structural dissociation. Means the long-term consequences of the first part, okay, this engages upper level circuitry, which we have talked about, everything that is above the brain, above the midbrain, that is basal ganglia, thalamus, cortex, CSTC loops. But it is energized by the lower circuitry, that is all those amygdala. We talked of tectum, tegmentum, and periaqueductal gray. Now, if we look at these two separate circuits, this will keep on getting activated over and over again because of this thing going on and on. The setting of this circuit is very, very, how would you say, instantaneous. So anything small can trigger off this circuit. And then these things will happen. The dual between an upper level circuit and lower level circuit. Upper will try to control, inhibit, the lower will keep on going. So this is called a structural dissociation. So with this, the activity, or let's say the dissociation starts. With this, the dissociative symptoms or phenomenology sets. Right? So it is something like this. So when we look at what is happening, initially we have this, let's say, exposure to stress. We have the flight or fight response, sympathetic dominance. That is the time when the endocannabinoids kick in. This is what we are understanding these days, that this endocannabinoid system that we have inside the body, similar to the endogenous opiate system, mediates the early experiences of dealing with stressful situations, right? So once this flight or fight response is there, everything, this is a defense reaction. So hyperarousal, hypervigilance. Also, this is dorsal PAG mediated. Dorsal PAG would be sympathetic, and ventrolateral would be parasympathetic kind of. Okay. So this leads to tonic immobility, depersonalization, derealization because of this mu opioids, basically the endogenous opiate system, because endogenous opiate system is normally has got a soothing effect, reduction of pain. But if it is overactive, it makes somebody very passive and tonically immobile. You cannot do anything. So this is what happens when there is the first part of neurochemical dissociation. What also happens is there is something called a selective thalamic deafferentation of the cortex. So whenever there's a lot of information going up from the lower areas, that's the lower circuit, the thalamus may not be able to filter out everything that is not needed. So some things will go up which are not needed. So there is a problem of integration that happens in the cortical levels. At the prefrontal level, or that is a problem of integrating thoughts, feelings, and experiences into consciousness and memory. This is not cohesive. There will be some things more or less, some things have not been understood properly, some things have not gone into conscious this thing because that integration doesn't happen. Why? Because there is something called as thalamic deafferentation. Because of this, there is also disruption of body awareness, because one is that we label the experience properly. Now, labeling means what? This is happening to me. That label of I understand this, so it is my thoughts. That this is not okay, that is my feelings, and I am aware of it because consciousness is intact, and then I remember it. Now, when this deafferentation happens, something or the other of these 3-4 things, that is thought, feelings, consciousness, and memory, might not get the true the true picture, so to say, in very simple words, and so the integration of the experience becomes problematic. Some of, let's say, if it happens that some of it is not labeled in my some of it doesn't go in my memory. If asked about it later, I might have no idea whether it happened, where it happened. So something like an amnesia happening here. Or I was not aware that for a certain period of time because things didn't, because the integration into consciousness was not happening. So around that time, if something has happened, okay, and I'm not aware, I might be in a different place, I might be in a different time, and all those things will not get registered. And so with thoughts and feelings, that feeling of unreality, whether it is my experience or is it so, that kind of thing. This happens because of this selective thalamic deafferentation. There is disrupted body awareness. Now, what happens is that along with all this information that is coming from the thalamus, the lower circuit that we talked about, this insula is one thing which also picks up body cues, irrespective of what is happening outside, irrespective of information that is coming from the thalamus. It picks up its own cues from autonomic nervous system, from various functions or physiological changes that are happening in the body. And then it also integrates into a complete body awareness, kind of a proper map. That doesn't happen. So roughly, this is what people have come to, kind of an understanding, which may again over time change, that like two things, PTSD and dissociation. So in a combination of PTSD, because this is an exposure to a traumatic event, and this is basically dissociation, means something or the other of this is happening. In this, there is an increased connectivity between the insula and cortical areas involved in sensory motor processing and environmental monitoring, resulting in a hypersensitive and a hyperaroused state. Means what? These two things, the cortex and the insula, they are deeply connected, and these connections keep going on and on and on. So everything that is happening gets over-processed. Over-processed means thoughts get over-processed, feelings get over-processed, memory gets over-processed. So a lot of arousal, that is what is PTSD, hyperarousal, remembering the same things again and again. In dreams, there are nightmares of the same thing, avoidance behaviors because of a hyperaroused state or a hypersensitive state. But in pure dissociative disorders, where there is no PTSD, the insula shows increased connectivity with more posterior cortical areas. This is more anterior, this is more posterior. involved in implicit neural processing. So this doesn't come so much in the conscious awareness. It's an overdependence on past experiences as compared to conscious awareness. So dissociative symptoms are more of lack of something, lack of awareness, lack of memory, lack of consciousness, whereas PTSD is more of re-experiencing. So both of them will have a similar pattern or a path, but the outcomes are different depending on how the connectivity works, right? So this is just to show a little bit more of a diagram, more informative on the amygdala. So how amygdala receives information from where nucleus basalis of Maynard, that is acetylcholinergic, sensory cortex association, insular cortex, striatum and it projects upwards to the striatum through the thalamus to the cortices, anterior cingulate, and also to the hypothalamus. So basically, this is the whole circuit from the amygdala perspective. But final outcome is autonomic arousal. So the perception of the so what I'm experiencing is going to be anxiety, increased heart rate, not feeling okay, that kind of thing. But amygdala also, along with all these structures, this striatum, prefrontal cortex, medial temporal lobe, sensory cortex, cerebellum, HPA axis is associated with conditional emotional learning. So those memories that are going to be stored will have this emotional value, which is given by the amygdala. So, it involves actually all kinds of memories, working memory, prospective memory, semantic memory, your declarative memory, all kinds of memory and at all stages. Right. So now when we have this kind of a system, which is there, we need to try and understand that why some people have, let's say, dissociative disorders. Why does the brain function in that way? And for that, we need to kind of take a peek into more basic processes. That is the genetics. So what have we understood till now? Now, first of all, let me make it very clear that when it comes to genetics of dissociative disorders, first and foremost, dissociative disorders are not one. There are at least DSM-5 gives 4 or 5. And on top of that, they are not very clearly defined. They are overlapping and they overlap with other disorders also. So to figure out an exclusive genetics has not happened now. But what we have found, the genes implicated are those which kind of regulate monoaminergic transmission, that is 5-HTT and COMT, neural plasticity, that is BDNF, neuropeptide receptors like oxytocin, and HPA axis regulators like FKBP5. Now, these are not specific only for dissociation. This we will find also in depressive disorders or anxiety disorders. So these are non-specific, but these have been found to be more strongly associated than anything else. But from a genetic perspective, what studies show is that there is a poor response to serotonergic antidepressants in patients being treated for other disorders. So if somebody has dissociation and depression, I give an SSRI, the response may not be great. Why? Because the nature of the disorder, of those two disorders, or let's say the dissociation that happens, the function of dissociation is such that maybe the reactivity of that individual, depressed individual, to SSRI is not great. But that again will force us to think how these two are different and where they vary. Pharmacological manipulation of serotonergic neurotransmission can induce dissociative symptoms. Levels of noradrenaline and dopamine are found to be elevated in certain depressive states. Yes, we know that because we looked at all the sympathetic overactivity. Also associated with higher levels of oxytocin and prolactin. Why that happens, we are definitely not sure. And pathological and non-pathological dissociative experiences are associated with distinct alterations in cortisol secretion, with pathological being hypercortisolemic and non-pathological being not so hypercortisolemic.
Dr. Dave, we'll have to wind up.
5 minutes.
Well, we are 7 minutes over time already.
Okay, so just give me 2-3 minutes. I'll just wind up. It won't take more time. And other genes that we have involved are this ADY-C8, DPP6, and APB2. What is also important is the last one in genetics, that this APBB2 is associated with dementia. So one line of thought is whether when dissociative disorders progress, whether these are initial presentations of a dementia that will come in later age. This genetics sets the tone for early attachment issues, stress, and opioidergic activation. That is why these systems are overactive right from the word go, because of genetics leading to early attachment issues, stress, opioidergic activation, and a baseline emotional dysregulation in PTSD and dissociative disorders. A number of studies have done from the imaging point of view, whether it's MRI or functional, and they have given us certain things. But again, if you look at the whole picture and if you look at psychiatric disorders in total, these are not much different or really specific. Small studies, not very well controlled studies, these things are not replicable, but some of the findings are here. We may not get into details of it at the moment. Okay. This is basically the fMRI picture of what I just described, what happens with PTSD, what happens when there is a dissociative subtype, which is goes along with that. Okay. In the management, what do we need to look at? Well, there are different forms: amnesia, identity, depersonalization, and these are overlapping. So it's not going to be straightforward. These are cross-cutting, and dissociative symptoms are present in all kinds of psychiatric disorders, substance use disorders, neurocognitive and neurological disorders. And of course, factitious and malingering, because they can be very confusing for us to figure out whether this is happening, because we always rely on the information that is given to us. We have no way of doing a test, a genetic test or a blood test or an imaging to actually confidently say that this is dissociation. What are the treatment modalities? Safety precautions, especially if there is multiple identity disorder or fugue states. All kinds of therapies have been tried along with hypnosis. But what do? Do they actually address the core pathology? No, because the core pathology is something else, which is more basic, starts from a genetic level to predispositions in systems, leading to attachment issues, overreactive response or an exaggerated response to stressful situations. That is there. So some aspects might be helped with the therapy. But in terms of pharmacotherapy, what do we look at? So rather than looking at the whole symptom, I would like to look at autonomic nervous stabilization, because that is overworking, agitation that comes from time to time, stress sensitivity, because there is a little bit of stress and it kind of triggers the whole thing, impulse control issues. Benzodiazepines, not very good response unless there are panic attacks or something. If it is more on the, some of them may look like complex partial seizures, so there would be a role of anti-epileptic drugs or ECTs. So with that, I end my presentation. Over to you, sir. Thank you so much.
Thank you, Malay. This is a very exhaustive presentation, and I'm sure it sets a different tone for the management of dissociative disorders. Since we're out of time, Dr. Aarti, would you have any quick comments that you'd like to offer?
Nothing to comment on, except that the presentation was really exhausting, as you had just rightly pointed out. I would also like to, ask if this could be translated in some other form in the management, if we could help out patients in neurocognitive training, or some form of newer neuromodulation therapies, if it could be helped out.
Yes. So neuromodulated therapies are there, but if we are looking at, because ECT is something where, if the patients are really suicidal, or the typical indications for ECTs. Other neurostimulation methods like RTMS can be tried, but for many disorders, RTMS doesn't work so well. So actually the research of all these things on dissociative disorders is very less. There might be case reports here and there. But the idea is that if we have some methods by which we can, let's say, if we have, let's say, theoretically, we have some probes which can, or some placements which can focus on an overactive amygdala, for example. This is again hypothetical. If we can quieten down its responsivity, it can help. The only thing as of now that can reach there is some molecule rather than some stimulation. Because what does happen is that here in disorders like this, the information that is coming from lower brain areas is not, is first of all, it is excessive because of all these systems that are overworking at a lower level. Plus, top down, means at a cortical level, we are not able to, rather the cortical input is not able to inhibit or kind of selectively eliminate some things which are not there. We can do a lot of, maybe try some cognitive training, but these things happen so quickly because the response to a stressful situation is kind of hijacked by the lower centers even before there is a top down kind of, okay, this is the strategy, this should be inhibited, do not work. So we need to look at it really more carefully. This is just a taste of things that we know. So it's also from the practical purposes, we can tell patients that things happen, you should not get worried, don't react. So what we are trying to do is, kind of appeal to that person's cortex that, okay, the inhibition can happen. You do not need to react everything. You should take time to evaluate situation. But then that doesn't happen because there are too many components in this whole machinery which need some tweaking up or down. So unless we understand these things better, maybe we stick to, at the moment, we stick to what we are doing best. But this model, these things that I talked about, actually can give us a chance to explain what is happening to the patients and relatives better.
Thank you, Dr. Dave. So I will add my 2 cents there that yes, we did some work with RTMS in dissociative disorders. We've did about 8 patients on this with PET scanning, and we're looking at hypermetabolic and hypermetabolic states, like what Dr. Dave said, and strengthening the top-down.
Yes.
So stimulatory in the dorsolateral prefrontal cortices, both sides. And inhibitory, we can't reach the thalamus, but inhibitory stimulation in some of the circuits. I'll be happy to share the protocols on a different, on a one-to-one basis. If anybody would be so interested, we are out of time. So thank you, Dr. Aarti,
thank you, sir,
for co-chairing. And of course, thank you, Dr. Dave. With this, we close this session. Thank you very much.
Thank you.
Okay, Doctor. Thank you, Dr. Dave. Thank you, Dr. Sunil. Thank you, Dr. Aarti. So we'll move on to next session. It's Ask the Expert session. It is on neuromodulation in clinical practice. The experts are Dr. Avinash D'Souza and Dr. Urvaksh Mehta, and moderator is Dr. Vaibhavi PS. I'd like to introduce the moderator, Dr. Vaibhavi PS. She has done MD Psychiatry from SSIMS and RC Devangiri RGUHS University. Currently working as assistant professor at Department of Psychiatry at Adichunchanagiri Institute of Medical Science, BG Nagara. She has won IPS South Zone, Dr. SM Channa Basavanna Spandana Psychiatry PGPs in 2021. She has done multiple research and publications in her name. I'd also like to introduce our 2 experts, Dr. Avinash D'Souza. He has been research associate at LTMMC and GH with more than 800 publications to his credit. Consultant with a private practice at Santa Cruz. Past president of Bombay Psychiatry Society, past secretary of IABP, and current secretary of IAPP, honorary editor of Annals of Indian Psychiatry, and is editor of Indian Journal of Mental Health. Our second expert is Dr. Urvaksh Mehta. Dr. Urvaksh Mehta is additional professor of psychiatry at the NIMHANS, Bangalore. Apart from coordinating and supervising clinical services in general adult psychiatry at NIMHANS, Dr. Mehta's research work uses a combination of transcranial magnetic stimulation, magnetic resonance imaging, genetic and cognitive assessments, and digital phenotyping to understand several mental disorders like schizophrenia and bipolar disorders through a social neuroscience perspective. He has published his findings in several national and international peer-reviewed scientific journals and has won several awards for the same. He takes keen interest in public and student engagement on the theme of mental health and its causal underpinnings. He is also the associate editor of the journal Schizophrenia Research. I'll now hand over to Dr. Vaibhavi.
Very
Yes,
good
Dr.
afternoon,
Abhay.
everyone. Thank you, Dr. Alkesh, sir. I would like to open the session for experts for today's session, Dr. Avinash D'Souza, sir, and Dr. Uvash Mehta, sir. And to begin with, I think I would like to invite Dr. Avinash D'Souza, sir, to open the session.
Okay. Good afternoon, everyone. It's an absolute pleasure to be here. The whole purpose of this session is that we answer queries on TMS. I am coming in more from a private practice perspective. So how do we use TMS in a private practice setting? What are the challenges we face? What are the issues we face? It's very different from using TMS in a medical college setting or in a research setting. And well, I have been using TMS for the past, I think since 2009, and I have been, very happy with the results in many cases. I'm here basically to share what I do and how I do. I use the Indian machine, and I think that's a better choice. Of course, there are better foreign machines. I don't deny that. But the thing is, the whole aim of today's session is to put in perspective a real life viewpoint about TMS. And I think that's what I would like to start with. Yeah.
Thank you, sir. May I now invite Dr. Uvash Mehta, sir, to open the session as well.
Hello, everyone. A very good afternoon. Thank you for having me over. So my perspective to this interactive session would be from our experience of using, again, although it is neuromodulation, I think both of us have experience working primarily in TMS. So that is something which we would focus on. So I would like to emphasize the idea of the clinical space for TMS. Now, TMS has been in place for quite some time, and over the years, especially in the last few years, the availability of TMS has increased. A lot of places in India have access to TMS. So having that information, how do we define the clinical space? And by clinical space, I mean it is applying or matching a clinical scenario to an available form of effective treatment and utilizing it in terms of implementing that treatment. So the clinical space for, say, for example, an antipsychotic for schizophrenia is huge. A clinical space for TMS for depression, clinical space for TMS in OCD, in substance use. So these are some of the areas where TMS has grown, and I would perhaps take the yardstick of go beyond randomized control trials and see what the regulatory bodies have approved. And you can take FDA as one example, and you can see that over the years, TMS has garnered approvals for various indications, especially depression, OCD, and substance. Having said that, OCD and substance, it is primarily for deep TMS. It is a different type of TMS, which requires a different machine, a different coil system, as opposed to the conventional form of TMS, whose accessibility is much more. And in that kind of TMS, its primary application is depression. So with that background, I'll close my comments here, and I'll be happy to take questions.
Yes, sir. Thank you, sir. I have a question from Dr. Tejesh to Dr. Avinash D'Souza, sir. So we would like to know the experience of TMS in your clinical practice in the private practice.
Okay, so in a private practice setup, see, I started using TMS first, primarily for major depression. And I, of course, have used it in adult patients and older patients. In the last 5 years, I have used it in a few patients about the age of 14. Now, the thing is, primarily, there were different protocols when I looked at literature for the use of TMS. So there was a left-right alternate. There was a left-right on the same day. There was left-sided stimulation primarily. And I found that left-sided stimulation, when you start probably at 3 to 5 PPS and go up to 15 or 20 PPS, it's something that worked pretty well. There were some patients where with the right stimulation, they complain of some negativity, some sluggishness, some issues. So I have stuck to a left-sided protocol in my practice, and I found that more effective. The challenge is, I think, so that is one major indication. The second major indication is I've used RTMS for resistant auditory hallucinations in schizophrenia, where I found it to be very effective, and that is where I've also found TDCS to be quite effective. So now the issue here is that in a private setup, TMS can be done well for a patient who's probably staying nearby to your clinic, maybe at a half an hour travel distance, or someone who is ready to travel if he wants treatment, because I follow a protocol wherein I normally ask the patient to come in at least 5 days a week, and then probably have a gap of 2 days. The reason I propose a 5 day is because it will always happen that the patient may miss 1 day in between. It can happen due to something that comes up. So there's no major gap in treatment that happens. If possible, we even have a 6-day daily TMS followed by Sunday gap, and then we sort of take a call. That is for MDD, and the same goes for hallucinations. Patients who can't come in regularly because they stay far away, maximum we can permit is a 4 times a week protocol, but lesser than that, the efficacy of TMS definitely is compromised. So my suggestion is a 5 times a week or a 6 times a week protocol ideally works best. And TDCS is something that I offer patients who stay far away from me because it's safe, it's easy to use, the device is portable, they can take it home. We can even explain to them how to use it on a video call. So, and that is something that they have to take twice a day with a gap of 6 to 8 hours between 2 sessions. And it's not practically possible for them to come to the clinic twice a day. So that is something they can take home and use. One very important factor, majority, around 75% of my patients have been on concomitant medication. But there has been a group of patients, 25%, who probably didn't want to take medication for some reason, either side effects of previous prescriptions or just their own negativity and bias towards not taking medication, where we've used pure RTMS. And we've seen effects even with RTMS, so it does mean that RTMS works. There are a lot of people who haven't used it but try to blush it away, saying it's a placebo. I don't think it's placebo. It does work. And yes, and I think I'll just add one more thing, that when I started using it in 2000, I think 9 or 10, the Indian machine was available. I mean, we had also international machines which were available. The cost of the machine was far, far cheaper. But the thing is that I always found the Indian machine more feasible for the very simple reason that A, the cost was less. Secondly, also for that matter, that the engineers for these machines are available very easily if there's any problem that arises with the machine. In a private setting, you can't just stop treatment midway and tell the patient, I'm sorry, my machine is conked off, and so the treatment won't continue. So that will give your clinic a bad name. So it's important that you have somebody who can come immediately and fix it. A 1 day gap, you can always excuse yourself saying that the machine needs to be fixed. So this is my advice. I'm not going to name a brand or a company, but make sure whichever machine you buy, that you have engineers around you to come if there's anything that goes wrong, like a fuse going off or something with the circuit or anything that can go wrong. Yes, I think I'll hand over to Urvat. He's more, I'm a big fan of his. I read a lot of his work, so I'll hand over to him. Yeah.
Yes, sir. Thank you, sir, for sharing your experience. We are going to hear from Dr. Urvat, sir. So we would like to know your experience. What modality of neuromodulation have you used the most and for what indication? And if you can throw more light on the setup you have at the moment at your institution.
Yeah. So if we restrict ourselves to, it depends on what diagnosis, what modality is available. So Dr. Avinash mentioned about TMS and TDCS. ECT is also coming under the broad rubric of neuromodulation. Perhaps we focus on TMS because that is what we have worked with. So in our work, it is primarily used in depression. We get a lot of referrals for a host of disorders, especially resistant conditions. Some are valid enough referrals because there is some evidence to support the use, like what Dr. Avinash mentioned, persistent auditory hallucinations or negative symptoms of schizophrenia. Some are perhaps out of sheer trying everything and not working, and then wanting to try something new for a particular patient. So we get referrals. We have given TMS for a host of rare disorders also. But by far the most common indication it remains is depression. So in this area, I would like to emphasize the idea of the clinical space that I was mentioning, especially for TMS and depression. So I would perhaps like to ask the audience and the young psychiatrists, when you sit in your patients, within your practice or during your training, you would have come across a lot of patients with depression. So I want to ask you, how often did you think that, oh yes, this patient, I tend to prescribe TMS. This is a patient where I want to give TMS. That if you start thinking in that direction, then perhaps you will wonder that where is the clinical space. So as mentioned earlier, there are a lot of skeptics about TMS. Although for depression, I think there is convincing evidence that TMS definitely is useful. It is superior than placebo treatment. So there's no doubt that TMS works. So let us believe that TMS works in the treatment of depression. But there are other treatments which are, you have antidepressants. If they don't work, if they are partially helping, then you can augment with other psychopharmacological agents. You can use cognitive behavioral therapy, you can use ketamine, you can use ECT. So where is it that where is the space for TMS in this crowded pool of treatments which are already available for depression? So that is an important question to answer. And in my opinion, there are 3 or 4 areas. The first area is where you are treating someone with an antidepressant for the first time and you find either partial or no response. So one line of antidepressant failure or partial response, that is a good candidate to choose for TMS, because you wouldn't want to give ECT, you wouldn't want ketamine, because it's just the beginning of treatment and there is some partial response. You wouldn't choose more aggressive treatment there. So TMS can sort of help, and that is the most common global indication, and that first line treatment resistance. The second area would be where there is a perceived need for faster improvement, where you can combine SSRIs or TCS with, and there is now evidence to show that if you combine TMS with psychopharmacological treatments, then the treatment response can be faster than psychopharmacology alone. So that is another example. A common clinical scenario would be if someone has an exam and has severe not so severe to necessitate ECT, but you want faster improvement because there is an exam after 10 days. That is a good scenario where you can perhaps try TMS, and we have had such experience where TMS helped. The third and fairly rapidly growing field where TMS has a space, clinical space, is in elderly with multiple medical comorbidities and poor tolerability to medication. So a common presentation to us is elderly depressed with poor tolerability to escitalopram or sertraline or fluoxetine. Most commonly, they develop hyponatremia. And with repeated SSRIs, different lines of SSRIs, they still continue to have hyponatremia. And the treating team finds it difficult to engage in any kind of pharmacological treatment. So that is a place where if you're not tolerating medicines, or if there is a contraindication based on general medical literature. So medical comorbidities with depression, PMS is definitely a growing role. So extending that, normal physiological conditions like pregnancy also. Now we know that based on the physics of PMS and also based on observation studies, that PMS has fairly little effect on the growing fetus, or it doesn't have, there are no adverse outcomes in terms of pregnancy. There are 2 longitudinal studies now which show that it is fairly safe to be used in pregnancy. So that is another indication on similar. And the last, like Dr. Avinash mentioned, is patient choice. That is also a growing field. We also do get patients who come, take TMS, get better in terms of the depression, go back without any pharmacology. And 3 years, 4 years down the line, if they have a recurrent depression, they come back again, take TMS and go back. So that's how it works. That's a minority. It's not a major indication, but these are the 4 spaces where TMS is applied in our practice.
Right, sir. Thank you. So I would have a question for Avinash sir. Sir, would like could you please share your experience of TMS with respect to autism and alcohol disorders in per se? Like how many patients you would have used, and how is the treatment outcome expected out of within months and weeks? Sir, you're muted.
There are some studies that have looked at RTMS being used to reduce craving in smoking cessation, which came first, and then alcohol dependence came later. Now, there was a time when we didn't have drugs like varenicline to help us in smoking cessation, and bupropion also didn't really work well. So that is when I combined RTMS and bupropion with a fair amount of success. I would say 60-70% reduction in smoking rates, which have worked. And there's also been some use in alcohol. I would say probably I've used it in around 30-40 patients, not more than that. But particularly for the craving component, and these were alcohol-dependent patients who also had mood issues. So I've used it primarily there, and we found it to be successful for both. With regard to autism, I have not had, I think, the bravado to use it in children with autism yet, but I have definitely used it in autistic adults and adults above 16 maybe, wherein I have primarily focused on it improving social communication and improving probably mood, because none of the medications worked. So we said, let us try and see. And one thing which was found is they were calmer, they were more attentive, they were more focused, and their overall social behavior showed at least a 20-30% improvement. I wouldn't say it showed a drastic change, but parents are very happy because a child who otherwise socially wouldn't mix became a little open to going into social situations and became a little open into sort of communicating socially. So, but then these have been, I have always told patients that these are off-label uses. I don't guarantee you any results. So what I have suggested to them is that we'll give you around 10 or 15 sessions. If you feel there's a change, then we'll probably give you the whole gamut of 30 to 40 sessions. Otherwise, if you feel after 10,
So you've muted yourself.
you feel after 10 sessions or 15 sessions, there is no improvement, then, we could look at stopping therapy there. So this is my experience in that area. I haven't, probably I've used it in around 8 or 10 adolescent adults with autism, not more than that, because not many parents are open to giving anything neuromodulatory to children with autism. But those who were, we took the chance, because their worry was, what if something else starts and this stops, something like that. So we said, no, nothing will happen. Let us see. And yeah, so that's my experience in that area.
Right, sir. Thank you. So I have a question from Dr. Varsha to Dr. Uvash, sir. So would you know the potential TMS or OCD and your experience with it, whether treatment resistant or whether we could start it as a primary line along with the medications is question. Go on, sir.
Yeah, so in all applications of TMS, you're free to use it as first line also. It's not necessary that you wait until treatment resistance starts. The only thing is that, as I said, the clinical need is perceived primarily when you've tried conventional or more common lines of treatment and they don't seem to work. Then you start wondering, should I try TMS or should I try some other treatment? So the same applies for depression, same applies for OCD. We have an experience of using TMS in OCD for quite some time now, and it started with low frequency stimulation to the pre-supplementary motor area that's just anterior to the vertex. So you locate the vertex, it's the highest point on the scalp, and then come a little anterior, that is supplementary or the pre-supplementary motor area, and use low frequency TMS there. Not great results from that protocol. There are mixed reports in that area as well. Subsequently, there has been a good amount of research done with deeper coils. So the circuits of OCD which are to be targeted in neuromodulation are deeper. You want to target the anterior cingulate, and you need deeper coils. So the basics of TMS is that the most important principle that you should understand is that the magnetic field decays with square of the distance. So as the distance increases, it exponentially decreases the magnetic field strength. So it is best at the superficial area, perhaps 2 to 3 centimeters deep. That is the traditional coil, the figure of 8 coil. But these days there are coil arrays which have overlapping coils which can penetrate deeper. So doesn't mean that it is only deep and not superficial. So it is superficial and deep, but it does reach some deeper. So there is a conical coil which is shaped at an angle, that is called the double cone coil. So you can use the double cone coil in targeting the slightly anterior to the supplementary motor area is the medial prefrontal, and below that would be the anterior cingulate. So you can use the double cone coil, or these days, as I said earlier, the deep TMS is available. So that deep TMS is a different machine. It comes with a different coil system. It is worn like a helmet, and it has a particular coil array for different regions. So there is a unique OTD coil which you can use and then stimulate. So in the last year and a half, we have used deep TMS also in addition to conventional TMS for OCD, and the results are encouraging. It is not about half the patients. We typically use it in treatment cases, at least one line treatment failure, and 40% to 45% patients do show clinically meaningful change. The deeper TMS comes with some caveats. The costs are very high. The coil orientation is specific for a particular disorder. Although they say that you can use it for other disorders, but it is typically manufactured in such a way that it targets a particular region. And because of the depth and the strength of magnetic stimulation, at least initially we found its tolerability to be slightly less in compared to others, but we have not had any patients drop out because of tolerability with PPMs.
Right. So thank you for the extensive inputs from both of you. I would like to ask if any closing comments from Dr. Avinash sir now.
Dr. G. Prasad Rao has raised his hand. Maybe he would like to comment.
Not really comment. I would just say that our experience in Asha Hospital, as Urvaksh was talking and Avinash was talking, for the last 2 years, we have the deep brains wave, and we are using a model. We are actually testing 3 models. One of the model is 3 sessions per day for 5 days. The second one is 2 sessions for 8 days. And third, of course, much more scattered. What's happening is the response seems to be much, we are actually, the rater is blinded for the treatment person. We only write and send, and there are independent raters. The initial result seems to be strikingly good for three important conditions. Of course, I'm talking about OCD, major depressive disorder, but we are also using we have another coil for addiction. I think Urvak should agree with me. That's that second coil which we have. All the coils are the kind of helmet-like thing. And I think we are having quite good. Right now, we have about 7 centers in our Hyderabad under ASHA. And for Urvash's sake, we also have 1 center in Bangalore. Hope you know that. We have ASHA center and 1 in Mysore too. So I think we are really excited that we think, and in fact, we kept ASHA neurostimulation centers. So that's our centers, independent centers. So, and some of you, I would invite all the people who are in Hyderabad, just come and see our centers. They're definitely a bit high tech, but good to look. And patient might get well even before going into the. And last but not the least, we have a neurophysiologist working in our team. Our neurophysiologist and about 10 psychologists, clinical psychologists are trained. What we are adding is a behavior therapy component for especially the OCD one, in which each patient gets a tailor-made for their own symptoms. So I thought I will add this to the larger information. And thanks, Avinash and Urvak. I think it's a good session going on, and nice to see Karsi also. Thank you.
Thank you so much, sir. Adding me being from Mysore, definitely I'll look into your center. I'll go and visit sometime. Thank you.
Vaibhavi, please go. And I would also encourage research there if you are interested.
Yes, sir, definitely. I will pay a visit. Thank you.
Sure.
Any final comments from Dr. Avinash sir and Dr. Uvash sir? Sir, you muted. Could you please unmute?
Neuromodulation is here to stay. I think that's what I will say. The future is definitely bright with regard to neuromodulation. We're going to have better machines, deeper coils, better protocols, better softwares that will guide us. We'll also have MRI guided neurostimulation, which is there. So I think the key thing is that we have to explore this as clinicians, because the future of psychiatry is definitely brain-based and genetic. So we have to go from that perspective, and it gives an added dimension to those, like you have a patient, he's doing very well with your antidepressants, but has so many sexual side effects that he says, I want to stop the medication. And what is my alternative if I relapse? I don't want to go back to the same medication. So we have neurostimulation as an alternative to offer to these patients, particularly with the deeper, better coils that we have. We definitely have it. And I think in OCD, it's going to open up a lot of avenues for treatment. So yeah, that's I think you all should buy TMS, try TMS, use TMS. Sony, the more you use it, the more you will get, aware of it. So that's my final take.
Thank you, sir. Dr. Uvash sir?
Yes, I would agree with Dr. Avinash that it's here to stay. It has been here for a long time now. 1980s, late 90s when it started. And the way ahead is, as I see it, is in 2 or 3 directions. One is improving the localization. We can use MRI or EEG to determine where and how precisely to target the location of stimulation, make it personalized based on physiological experiments. The second is you can also do e-field monitoring. You can actually understand how much of electrical field is entering the brain and stimulating the neurons, and then accordingly, based on the person's skull thickness and dura and CSF space and all, and then you can decide how much dose to give. So you don't have to rely always on the resting motor threshold. So that is another area. And the third is, as Dr. Prasad Rao also mentioned, there is an increasing need to examine accelerated protocols. That is another area where the field is moving towards. Everyone wants improvement faster, and although people are pushing boundaries, the boundaries seem to be safe as of now. So that is a third area which is progressing to study accelerated TMS protocols. And lastly, it has certainly use of TMS has definitely improved our understanding of the neurobiology or the neural circuits underlying several of these disorders, be it depression. So now we can confidently identify known neural circuits because we see what TMS does on fMRI and on in terms of symptoms in a randomized control trial. So that will give us a very good understanding, which has already given us a very good understanding of the neurology of auditory hallucinations, negative symptoms, cognitive impairments, and so on. So yes, so it contributes not just in treatment, but also furthering moving the field ahead in terms of understanding neurobiology.
Right, sir. Thank you. It was a fantastic session by both of you, two esteemed speakers and clinicians. To wrap it up, we got more inputs from Dr. Avinash sir regarding the various indications and also his personal experience on using with bupropion for NDS, that is nicotine dependence, and autism, that is a few of the adolescent kids, and also some autistic elderly patients to calm them down. And also, sir did give an option that this could be an alternative when there is sexual side effects. And from Dr. Urvash sir, we did learn about the skewed indications, as in we could narrow down patients as the patient selection, where there is treatment failure or there are elderly patients, or it is also indicated in pregnancy, and also in case we want to fasten the efficacy of the drugs along with, and also treat the patients in a faster range. So it was a wonderful session, and also sir did throw light on newer coils and newer protocols, which is wonderful to hear from both of you. Personally, I would like to thank Dr. Rukshita ma'am for giving me an opportunity, and IABP. Thank you very much. Have a nice day, everyone. Over to Dr. Alkesh, sir.
Thank you.
Thank you, Dr. Vaibhavi. Thank you, Dr. Avidas. Thank you, Dr. Urvax. We'll move on to the next session. So our next lecture is on treatment guidelines for bipolar disorder, clinical application and relevance. Our speaker for this session is Dr. Muralidharan Kesavan. For this, we have our two chairpersons, Dr. Venugopal Jhawar and Dr. Asad Hussain. Dr. Venugopal Jhawar has got some work, so he has informed that he will take some time. Till then, Dr. Asad Hussain will continue being the chairperson for the session. Regarding Dr. Asad Hussain, he is a primary affiliation as Professor, Institute of Mental Health and Neuroscience, Kashmir, Associated Hospital of Government Medical College, Srinagar. Expertise and interest are trauma, bipolar affective disorder, metabolic syndrome, neurocognitive disorders. Recognitions are in multiple societies like Japanese Society of Psychiatry and Neurology Fellowship, World Association of Social Psychiatry Fellowship, Fogarty Fellowship, guest editor, COVID Special Issue, Journal of Medical Sciences. He has about 96 publications, and his research gate score is 26.39. I'll request Dr. Arshad Hussain to introduce our speaker and also introduce our topic.
Thank you, Dr. Alkesh. It's wonderful to be here, and thanks to Dr. Rukshita and the International Biology Academy for giving me this opportunity to chair a wonderful session by one of the very learned speakers, Dr. Muralidharan Kesavan. Dr. Muralidharan is a medical student and professor at the Institute of Mental Health and Neurosciences. So he specializes in neuromodulation and conducts research in bipolar disorder, depression, and brain stimulation. His areas of research have been mood disorder and non-invasive brain stimulation. Today we'll be talking about treatment disorder. Their relevance on the clinical fields. What do you, Dr. Muralidharan?
Okay. Thank you, Professor Arshad, for the introduction, and thank you so much for having me on this important program. I'll share my slides now. Is it visible?
Yes, sir.
Yes.
And I hope I'm audible.
Yes, sir.
Wonderful. Thank you so much. So, a very good evening to all. And today I'll be talking about treatment guidelines for bipolar disorder, with some focus on the clinical applications and its relevance in clinical practice. So I have no conflict of interest to disclose, and I'd like to place on record my acknowledgements to the office bearers of IABP, as well as the organizing committee for inviting me to be a part of this program. So the outline of my presentation would be something like this, setting the context. I'll talk briefly about what are treatment guidelines, for bipolar disorder, what is the clinical application of these guidelines and relevance in clinical practice. So we all know that bipolar disorder is fairly prevalent. The lifetime estimates of bipolar disorder is about 2.4% as per WHO and 2.8% as per the National Mental Health Survey. We know that it ranks among the 10th leading cause of disability in the world among all the medical conditions put together. And the treatment gap for bipolar disorder is fairly high. Only about 30% of the patients who suffer from bipolar disorder have access to treatment. So when we talk about treatment guidelines, when we talk about treatments for bipolar disorder, we're actually only talking about 30% of the patients from the Indian population who are able to access psychiatric care. So what are the clinical challenges in bipolar disorder? Just to summarize, so some are challenges in diagnosis. A lot of times bipolar disorder remains untreated, particularly early in the course of the disorder, where a first episode of mania may be misdiagnosed as acute polymorphic psychosis, or say bipolar 2 disorder is misdiagnosed as a recurrent depressive disorder or major depression. A lot of times the treatment is inadequate, sometimes incorrect, and any of these could lead to exacerbations of mood episode, which further worsens the course of bipolar disorder. The key thing with bipolar disorder is that there are various phases of treatment. So during the episode, there is an acute phase of treatment, probably would require hospitalization too, or would require outpatient treatment. This is followed by a continuation phase of treatment for about 2 months, where the patient has attained remission, but is at a risk for relapse if the medications are not continued adequately. And this is followed by the maintenance phase, where the goal of treatment is to prevent new episodes or a recurrence either of the opposite pole or the same pole of mood episode going forward. So this is briefly the context. One of the key things with bipolar disorder is still recently, I'm talking about 20 years, till about 20 years ago, it was not considered as severely debilitating as probably schizophrenia. So that's one of the things that I think has changed over the last few years, at least in the last couple of decades, is that the acceptance among psychiatrists about the seriousness of the disorder has changed. So what are treatment guidelines? Treatment guidelines are systematically developed statements that assist prescribers in deciding what are appropriate treatments for specific clinical problems. So a lot of times the treatment guidelines come with some assessments, some risk-benefit analysis, and what are the alternate treatment options available. They usually give what are the optimal treatments available for a particular condition. So one of the important things of treatment guidelines is to beneficially influence prescriptions at all levels of healthcare, from the primary care to the tertiary care. If the guidelines are used, then it could ensure that patients get similar standards of care at all levels. There was this important article that was published in 2002 about the usefulness and limitations of treatment guidelines in psychiatry in general, not specific to bipolar disorder. So according to this article, there were 6 major benefits of using guidelines in psychiatry. So one was the implementation of best practice psychiatric treatments. The other important thing about guidelines was to educate psychiatrists and other mental health professionals about the various treatment options that are available for psychiatric disorders. It also was useful to provide information to patient and family about treatment options. It resulted in better funding, particularly in areas where insurance covers treatment costs. This also gave us some information about what are the gaps in the research base that, the gap between research and clinical practice that the guidelines would help us fill, and also important contributions towards the understanding the science or the neurobiology behind psychiatric disorders and its treatment. There are a lot of limitations too, most important being difficulty in implementation and what some authors feel is a reductionistic approach to medical care. And of course, the treatment guidelines won't take into account the various cultural differences that underlie psychiatric disorders and their treatment. So these were some of the important aspects that pertain to treatment guidelines in psychiatry. So what about treatment guidelines for bipolar disorder? So I'm just going to touch upon it very briefly for paucity of time. So there are a whole lot of guidelines for bipolar disorder. So the CANMAT guidelines, which is something that is used very often these days. So you had the first version released in 2005 and the most recent version in 2018. And in between, there were 3 updates for the 2005 version of CANMAT guidelines. The World Federation Society of Biological Psychiatry has released guidelines for bipolar disorder over the last 10 to 15 years. 3 or 4 different versions have come up, updated versions. The NICE guidelines are there. The British Association of Psychopharmacology, Royal Australian New Zealand College of Psychiatrists guidelines. In addition, you have the American Psychiatric Association with their own guidelines. There is there's another Texas Implementation of Medical Algorithms project. And of course, we have our very own Indian Psychiatric Society guidelines. One was released in 2005, and then the Clinical Practice Guidelines for Bipolar Disorder and a whole lot of other disorders were released in 2017. So why do we need guidelines for bipolar disorder? It's important because we need to know which is the best mood stabilizer that is available for treatment. We need to know whether a single drug would work or a combination of drugs are required. If choosing a combination, which one would work best in my patient? Do antidepressants have a role in bipolar disorder? Are atypical antipsychotics as efficacious as mood stabilizers? Can they be used as mood stabilizers? If so, what is the safety and efficacy of these drugs? Do I need to have similar strategies, or do I have to have different strategies to treat bipolar 1 and 2 disorder? So these are broadly some of the questions that clinicians would have and what we hope the guidelines would help answer. So the guidelines would help us find some of these answers, at least if not all. They help us by systematically reviewing the research evidence for efficacy, safety, and tolerability of drugs. We do know that while some drugs are very efficacious, the safety profile and tolerability makes it difficult for patients to use. The most common example that I would give for bipolar disorder is carbamazepine. If you look at all the network meta-analysis for mania, carbamazepine comes out as the most efficacious drug, but then the safety profile and tolerability have ensured that we don't use it as a first-line drug. We also need to, the guidelines also give us some predefined criteria for classifying the levels of evidence, treatment recommendations based on evidence. Sometimes when there is very little evidence on a particular area, let's say, for example, bipolar disorder in pregnancy or bipolar disorder in the elderly, expert consensus opinion is also provided as part of the guideline. And most guidelines come with a treatment algorithm. So what is a stepwise approach to treating bipolar disorder? So again, I'll probably skip this slide. So there are guidelines on how to grade treatment evidence for clinical guidelines. So if you're interested, maybe you could look it up. It's from the World Journal of Biological Psychiatry in 2019. So the content of guidelines are pretty much similar. So what are the pharmacological interventions that are available for acute mania, acute bipolar depression, maintenance treatment, rapid cycling? They also talk about the safety and tolerability profile, including pregnancy, lactation, and special populations. There is also some information on, say, special conditions, like, for example, guidelines for mixed affective states. Some guidelines also give us some information about the evidence for the use of psychosocial interventions, particularly important in bipolar disorder, where psychoeducation, group psychoeducation, interpersonal social rhythm therapy, these are all some things that are being used routinely in clinical practice. So to have evidence-based guidance is something that would be very crucial. Finally, application of guidelines in clinical practice would always mean that we have to tailor it to the individual patient's clinical history. So take the information from the guidelines, adapt it to the individual patient. So what are the clinical applications? So let's look at acute mania first. So we had the opportunity to review some of the evidence for a recent publication by the Indian Psychiatric Society South Zone. So we did summarize that evidence from 4 guidelines. One is from the RANSIP, CANMAT, the clinical practice guidelines from the Indian Psychiatric Society, and the British Association of Psychopharmacology guidelines. So if you look at the drugs that are recommended for the acute treatment of a manic episode, it's more or less similar across guidelines. You'd find that lithium and valproate appear in all guidelines, or most guidelines. And you also have the second generation antipsychotics like olanzapine, risperidone, quetiapine, asinapine, which are all recommended as first-line treatments. The only difference is probably in the CANMAT guidelines, which has pushed olanzapine to the second line, but that has more to do with tolerability and safety rather than efficacy. And then there's a treatment algorithm that we were able to get, which talks about initially optimizing treatments like lithium, quetiapine, or any of the SGAs. The next step, if the response is not adequate in about 3 weeks' time, to add on a switch to alternate treatments. The step 3 is to switch treatments with various other agents and use combination therapies. So the fourth one is to look at third line treatment. Step 4 is to look at what are third line treatments for the treatment of acute manic episodes. So again, this is a network meta-analysis that spoke about bipolar mania. What are the pharmacological treatments that are available? As you can see, like I did mention, tamoxifen and carbamazepine rank very high in terms of their efficacy. But when you talk about discontinuation rates, then you find that olanzapine, quetiapine, paliperidone, these are the drugs that are associated with higher discontinuation. Lithium will feature somewhere in the middle in both the lists. So this basically tells us that most of the drugs that are available are quite efficacious as far as treatment of mania is concerned, but it's the safety and tolerability that would actually determine how effectively it's used in clinical practice. This is just a schematic representation of the network meta-analysis. The thickness of the bars merely indicates the number of studies that have been done between the two drugs. As you can see, most of them are connected to placebo. So most of the comparator studies have used placebo. Some of them have used haloperidol. Some studies have used risperidone. So this is just a schematic representation of the network meta-analysis. So what are the challenges when it comes to treating an acute manic episode? We need to know what happens after the first episode of mania. And how long do you continue prophylaxis after the first episode of mania? So these are questions that are routinely asked for which we don't have answers usually. So what happens after the first episode of mania? From what I've reviewed from literature, we find that there are 2 or 3 studies that have been published. One of this is from the Mood Disorders Center in Vancouver. So what they have reported is that 78% of the patients recover over a 4-year period. 78% recurrences occur over a 4-year period. Sorry, I think that's a mistake. 60% are depressive recurrences and 28% are manic recurrences. And the mean time to recovery was about 85 days after the first episode of mania, which seems to be quite high. This is a chart review that we did and published from NIMHANS, where we looked at what happens over 5 years after the first manic episode. And we found that most of the patients tend to have a relapse of the manic episode within 12 months. And most of them, almost all of them, had a relapse or a recurrence within 5 years from the first manic episode. Incidentally, the number of manic episodes outnumbered depressive episodes by 2:1. So the patients experienced twice the number of manic episodes as depressive episodes in a 5-year period. So this has important implications for prophylactic management and whether to stop treatment after the first episode of mania or not. So how long to continue prophylaxis? Again, this is something that is controversial. Different people would say different things. The traditional teaching was to continue for 6 months or 2 years after the episode, but lifelong prophylaxis is recommended in most of the guidelines. And severity of the mania is considered, as a pointer towards how long prophylaxis is required. Some important clinical pointers being presence of psychotic symptoms, need for hospitalization, the recommendation to use electroconvulsive therapy. So these are some of the things that are looked at as pointers of severity of mania. A lot of times the risks of not continuing prophylaxis probably outweigh the benefits. Hence, the clinicians would need to take a call based on the clinical profile of the patient as to whether they would want to continue prophylaxis or not. What do Indian psychiatrists do? So this was a study that was published in 2019 in Australian New Zealand Journal of Psychiatry. And I think some of our committee members from IABP are co-authors on this particular project. So you find that in India, most of the psychiatrists of the 500 who were polled, 269 of them said that they would use a combination of mood stabilizer and atypical antipsychotic, whereas 55 said they would use. So in terms of percentages, I think it's about 54% said they would use an atypical antipsychotic and mood stabilizer as the first preference. Very few people said that they would use antipsychotic alone, only about 8%. And the number of people who said they will use lithium alone or valproate alone with or without benzodiazepine is very, very small. So contrary to what the guidelines are recommending, in clinical practice, we appear to be using a combination of a mood stabilizer and an atypical antipsychotic a lot more than using either of these drugs alone. So going on to acute bipolar depression, we know that treating bipolar depression is a lot more challenging than treating mania, particularly when you have a situation like this where the course of illness starts off with a depressive episode and the clinician is left to decide whether we're looking at potentially a bipolar depressive episode or a unipolar depressive episode, particularly in young individuals who come to us for treatment. So that's an important diagnostic challenge. Again, the common problems with treating bipolar depression is misdiagnosis. Like I said, particularly bipolar 2 disorder is misdiagnosed as recurrent depression. So the treatment of the depressive episode usually follows that of a major depressive disorder. Predominates the course of bipolar disorder, even in the Indian population. By this, I mean that even though the number of manic episodes are that much higher in our Indian population, the time spent in depression is a lot more. So if a patient has had 3 manic episodes and say only 1 depressive episode, it's likely that the patient spent only about 3 months in total in manic episodes, whereas in depression, they may have spent about 8 to 12 months. So it predominates the course of bipolar disorder in terms of the days ill. Inter-episode depressive symptoms are very common, even in patients who have multiple manic episodes. We have very few therapeutic options for acute bipolar depression, and if we don't use it effectively or rationally, the treatment options get exhausted fairly rapidly. So this is something that most of you would be aware. I'm not going to go into details. What are the features that would help us differentiate bipolar and unipolar depression? Of course, positive family history of bipolar disorder, atypical depressive symptoms, psychomotor retardation, reverse vegetative signs. All these are pointers, psychotic symptoms, all are pointers towards bipolarity. So again, going back to this review that we did, so we looked at the same guidelines, and most of the guidelines would look at what is the monotherapy or combination therapy that can be recommended as first choice. And across guidelines, you'd find that lithium, quetiapine, lamotrigine, these were all drugs that were seen as first choice drugs, or the first line drugs to treat acute bipolar depression. The difference between RANCIP and CANMAT guidelines is that valproate was considered first line in RANCIP, whereas divalproate was seen as the second line treatment in CANMAT guidelines. Coming to the IPS guidelines, the clinical practice guidelines, we find that lithium, lamotrigine, quetiapine, olanzapine, fluoxetine combination. Here we have this unique thing of valproate plus lithium. And of course, something that is very unique to our IPS guidelines, which probably reflects clinical practice, is a combination of an antidepressant with valproate to treat acute bipolar depression. The only other guideline which does recommend that too is the British Association of Pharmacology guidelines, which again talks about an antidepressants plus an atypical antipsychotic or mood stabilizer as a first line treatment. And of course, there are a whole lot of second and third line treatments that are available. So in terms of evidence for pharmacological treatments, again, there are a whole lot of studies which have been done, and this is a summary or the network meta-analysis of the available evidence. If you look at the number of placebo-controlled trials that are there, you find that there are 10 trials for antidepressants, 10 trials for anticonvulsants, 12 for antidepressants. There are about 13 trials of atypical antipsychotics mostly, and 6 agents have been used, the most common being aripiprazole, risperidone, quetiapine, olanzapine. So these are the common antipsychotics that have been tried. Lithium, there's 1 trial. And so totally, they reviewed about 9,485 subjects pooled from these 36 trials. So the treatment algorithm that follows the guideline is that initially you assess the patient adequately, particularly suicidal ideation, initiate and optimize treatments with various first-line drugs. If not working, then move on to an alternate treatment from among the first-line drugs. Third step is to add on treatments from the second-line drugs like valproate or add on an antidepressant. And the last step is to look at various other treatments that are available as third or fourth-line agents, or add on with various other third or fourth-line agents. Okay, so what do we do in terms of our clinical practice? So again, referring to this article that was published in 2019, so most of our psychiatrists, almost 27% of them, use a combination of mood stabilizer plus SSRI. And almost 25% of them report using a combination of a mood stabilizer plus quetiapine. Very few people use lithium alone, only about 5% of them. And as a second line treatment, a lot of them again use olanzapine fluoxetine combination as the first choice treatment, followed by mood stabilizer and SSRI. So if you look at combined data, you'd find that almost 50% of the psychiatrists in India use SSRI as either a first line or a second line treatment in combination with a mood stabilizer for treating acute bipolar depression. So some of the challenges that we face include what is the role of ECT in acute bipolar depression? Do antidepressants have a role in treating acute bipolar depression, and how long do you continue antidepressants? Again, there is some evidence that has been generated for the role of ECT. So most of the ECT guidelines will talk about ECT as a second-line treatment for acute bipolar depression. Switch rates are quite limited, so there is no real contraindication for using ECT in bipolar depression. So the question is, when do you start and when do you stop ECT? So what are the adequate number of ECTs? From the study that we found that ECT had comparable efficacy in treating both unipolar and bipolar depression. And of course, antidepressants and bipolar depression, like I just mentioned, most of the psychiatrists prescribed an antidepressant plus mood stabilizer for bipolar depression, and SSRIs are used by 88% of the psychiatrists in combination with the mood stabilizer to treat acute bipolar depression. Bupropion is not as commonly used in India as it is used elsewhere. And ECT is often first prescribed because a lot of patients present to us with suicidal ideation. This is again from the same article. Almost 41% of the psychiatrists prescribe ECT for mania not responding to medications. And among patients with depression, they prescribe mostly for patients with suicidal ideas or with significant psychomotor retardation. And almost 36% of the psychiatrists prescribe ECT to hasten recovery from it. And how long do you continue antidepressants? This is a recent article that we published in New England Journal of Medicine, where a collaborative study was done with the University of British Columbia. And we found that you could continue escitalopram for as long as 52 weeks under the cover of a mood stabilizing agent, so that the patient could continue to have the benefit of remission from depression without an added risk of switch to the opposite pole. So in terms of the clinical course of bipolar disorder, we know that they have both depressive and manic episodes. Western studies talk more about depressive episodes, whereas the Asian studies and Indian studies talk mostly about the mania predominant course of illness. This is again from what we had published a few years back. Manic episodes occur 3 times as frequently as depressive episode, which has significant implications in planning maintenance treatment. The goals of maintenance treatment being preventing severe symptomatic exacerbations of illness or preventing new mood episodes, addressing subsyndromal symptoms and residual symptoms, as well as enhancing overall health and function. So more often than not, we try and maintain the patient on the drug which was effective in the acute phase, which is usually determined by the polarity of the most recent episode. And pharmacotherapy is the mainstay of maintenance treatment. So again, going back to the evidence that we had an opportunity to review, most of the guidelines will talk about lithium as one of the most favored prophylactic agents or mood stabilizers, followed by valproate. Quetiapine is something that finds a place of late, and olanzapine has also been tried as a first-line drug for, particularly among the Indian psychiatrists who have used olanzapine as a prophylactic agent in acute bipolar, in the maintenance treatment of bipolar disorder. The second-line drugs include some of the long-acting injectables like risperidone, and most of the other drugs, or combination of an antipsychotic and mood stabilizing drug. Yeah, this is again the CANMAT guidelines, which talks about the first-line treatments, which are ranked in order of the efficacy as well as the available evidence in clinical practice. You find that lithium and quetiapine rank fairly high, followed by valproate. So what are the challenges when it comes to maintenance treatment? So what is the best drug available? What is the practice of maintenance treatment in India? And can we use long-acting injectables? So this is the data that was published. So when do people start prophylaxis in India? So very few people start after the first episode of mania, which is what I had brought up a little earlier. You find that only about 19% of the psychiatrists recommend maintenance treatment after the first manic episode, whereas the number increases substantially to 51% and to 77% if patient has had 2 episodes or more. So in general, while the guidelines do talk about the importance of prophylaxis from the first episode itself, what is reflected in clinical practice is that it's only after the second and most likely after the 3rd episode that we are comfortable in prescribing prophylactic treatment. And again, what is the drug that is preferred? More often than not, it appears to be valproate based on the poll conducted, followed by lithium. And third is mood stabilizer plus atypical antipsychotic. And if you can look at the last part of this table, you'll find that antipsychotics alone is not something that Indian psychiatrists appear to be comfortable in using as a prophylactic treatment. These days, we're talking about second generation antipsychotics being the new age mood stabilizers with quetiapine, cariprazine, and some of the other drugs that have been introduced, which have apparent prophylactic efficacy. But when it comes to prescribing, I think we are a lot less liberal with atypical antipsychotics as compared with the traditional mood stabilizers. Again, there's another study that was published from India where valproate outnumbered the number of people receiving lithium. So this is something that seems to be very common. Valproate seems to be gaining more preference among our psychiatrists as compared to lithium. So coming on to the last part of my presentation, relevance in clinical practice, I had an opportunity to review a few studies. So this was published in Biological Psychiatry, I think in 2023, pharmacotherapy for bipolar disorder. Again, it looked at the continental differences. So you would find that lithium prescriptions, if you look at the first table, the pharmacotherapy for bipolar disorder, the third part of the meta-analysis, lithium is preferably used in Europe and North America as compared to Australia, whereas mood stabilizer plus second generation antipsychotics are used a lot more liberally. So I think seems to be a difference in prescription patterns across continents. Likewise, in terms of the use of antidepressants, it appears that the use is a lot more liberal in Australia as compared to Europe and North America. So there are differences across countries in terms of the use of pharmacotherapy as well as in the prescription of antidepressants. In terms of the Asian countries, so this is a study that was published in 2022, which compared the prescription patterns across different countries. And you find that in India, the drug that is used most commonly is the mood stabilizing drug, followed by an antipsychotic, and antidepressants are also used in combination as compared to, say, some of the other countries. For example, South Korea, the antipsychotics are used more commonly than, in fact, if you look at most of the other countries, you would find that they use antipsychotics a lot more commonly in treating bipolar disorder prophylaxis as compared to India. Yes, so there it is. And the prescription patterns between countries. So simple polypharmacy, as per this article, means one mood stabilizer plus one antipsychotic, and complex polypharmacy means two mood stabilizers plus one or more antipsychotics, atypical antipsychotics. So you'd find that here also there seems to be some difference between India and the other countries. However, our psychiatrists, at least 53% of them, seem to prefer simple polypharmacy, which is a good thing, one mood stabilizer plus one antipsychotic in treating bipolar disorder, which is reflecting the findings of the earlier study published in Australian New Zealand Journal of Psychiatry. So here again, this particular article, again, the same article, what do psychiatrists in India do when it comes to reference to guidelines? It looks like about 85% of the psychiatrists polled said that they do refer to some kind of guidelines while prescribing, which is a very good thing. So almost 75% of them routinely look at Indian psychiatric guidelines, 85% looked at APA guidelines. So almost all of them appear to go by some degree of reference to guidelines to guide clinical practice. 25% of the practitioners said that they go with their own personal experience, and most of them said that guidelines do not answer all questions for the practitioner, which is absolutely true. Now, this is an article I thought I should share. Going by the prescription patterns that we are seeing, this was published in 2023, very recently, where the concerns have been raised with respect to using decline in use of lithium in bipolar disorder, a call to arms, as the authors call it. And they're talking about why it appears to be, there seems to be some kind of hesitancy in using lithium, and the use of second generation antipsychotics or anti-epileptic drugs like valproate are being advised more, and there is a need for a change in terms of our attitude towards lithium use. So this is a very good article, which I would request all of you to read if you do get the opportunity. So to summarize, in terms of what convinces our psychiatrists to use a particular treatment for bipolar disorder, 46% of them say guidelines, 25% say personal experience, and a lot of them also refer to other IPS guidelines and textbooks, which is fairly different from what psychiatrists in other countries do. So this French survey reported only about 12% of them refer to guidelines, and the North American study said only 8% of them refer to guidelines, which is surprising considering that a lot of guidelines come from these countries. So our psychiatrists seem to be better informed and more, what do we say, scientifically oriented in referring to guidelines while treating their patients. So that's very, very encouraging. In terms of implications of the use of guidelines, guidelines are relevant to clinical practice. Of course, real-world patients differ from clinical trial populations. So to extrapolate the findings of clinical trials to clinical practice always remains a challenge. The role of antidepressants in bipolar disorder remains unclear. Guidelines appear to conflict with real-world practice. Like I mentioned, most of the psychiatrists in India appear to be using a combination of SSRI with a mood stabilizer. There also appears to be a reluctance to provide maintenance treatment among psychiatrists in India, particularly soon after the first episode of mania. And that is something that would require a fair degree of research and debate. The role of ECT also remains different from what is recommended in guidelines. And of course, this is clearly dictated by clinical practice. So to conclude, we have a disorder that poses very unique diagnostic and treatment challenges. All phases of the disorder and all phases of treatment have its own set of challenges. So guidelines, like I mentioned, help us address some of these challenges, provided we tailor the recommendations that these guidelines provide to suit our individual patients. Thank you so much for your attention.
Thank you, Dr. Muneesan, for a wonderful presentation, very elaborative. I understand that it's a limitation of time, and organizers have been actually continuously SMSing me for trying to curtail this presentation, but because it's so wonderful, I thought that we should have the whole presentation. We can allow one question from the audience, if there is one. Dr. Alkesh, is there a question from audience?
I think I have asked all the questions and I've answered them too. So.
Yes, sir. But there are no questions yet.
Okay, so this is one thing, which I wanted to understand is when we say that, we think that the psychiatrists in India are well informed than the psychiatrists in the rest of the world regarding the guidelines. Could there be a bias, because once we do studies here, research of this kind at a place, we generally enroll psychiatrists which belong to academic institutions, are academic oriented, which is a sort of a group, rather than actually have the sample which is unbiased. And probably this bias tells us that most of the psychiatrists follow guidelines.
Sorry, sir, I couldn't register your question. I'm very sorry. Could you repeat it?
Yeah, I said that, because we concluded that the psychiatrists in India are much more informed about the guidelines than the psychiatrists outside. I said that could there be a bias, because once we do such studies and we take samples, it's usually from the academic psychiatrists all over the country, which are in touch through emails, through WhatsApp groups, and other things. Our academic institutions per se, rather than actually going to the level, the rural level, the ground level, and trying to find out how does it roll out there. For example, I was, my institution was part of two of the studies which you actually said about the prescription patterns, which was, which probably Professor Shinoff did from Japan. So, the samples were taken from, our institution. So obviously we do follow some guidelines. And probably if we had taken some samples from the rural area where psychiatrists prescribe, other psychiatrists from our older generation prescribe, probably the results would not have been the same as they were predicted from our institution. And that's what I said, that could there be a bias of that kind?
Yeah, I think that's a very, very important and valid point that you made. Those questions did come up in my mind too when I was reading this article when it was published. But I think the sampling technique that they used was fairly good. So they took 500 people from the IPS registry by a random sampling method. And that's how they were able to ensure that only the psychiatrists from the tertiary care institutions or academic institutions were not selectively polled. So in that sense, I think the methodology adopted by the investigators was quite robust, and which ensured that there was a fair degree of representation from across, and the bias from academia was kind of ruled out. Even otherwise, I would think that the findings are quite reflective of what is actually happening in clinical practice, both in the institutions and outside in private practice, because I think if you look at drug development for bipolar disorder or any disorder in general, the focus has been to maintain efficacy while minimizing side effects. And the newer drugs definitely offer fewer side effects than the older drugs. And I'm sure that is what is driving clinical practice too. And a lot of this evidence is usually obtained from the latest updates that the guidelines publish. Like, for example, if people are using cariprazine a lot more now than probably quetiapine, it is because cariprazine does not have the serious side effect of daytime drowsiness that becomes intolerable to the patient once they recover completely from bipolar disorder. So even though the patient may be doing well with quetiapine, a lot of times we switch over to cariprazine simply because that side effect is no longer tolerable, even though the efficacy was. So I think to me, it was very encouraging to see that Indian psychiatrists are using guidelines a lot more than what is reported from Western literature.
Then just another point of, because we said that valproate is used across the bipolar spectrum in most of the Indian psychiatrists. In fact, a lot of other countries as well. But the evidence of valproate per se is in acute mania, and we do not have that kind of robust evidence in the other spectrum of bipolar depression. On one side, we think that the evidence-based medicine is peptide, but then on the other side, valproate is the commonest drug being used across the spectrum.
True, very true. In fact, I think one of the concerns that I had when I looked at that particular findings that valproate is used fairly extensively is that are we prescribing valproate even in women of childbearing age? Now, that is a concern that does come up. I don't find that information in the data that has been published because we usually associate bipolar disorder with the second decade of life or the third decade of life, and the onset is by early 20s. So if you're looking at valproate prescriptions being very common as a mood stabilizing drug, that would always raise a flag that are we prescribing this in women of childbearing age? If yes, then that is quite a serious concern that we need to look at. Considering that the incidence of bipolar disorder is fairly it's fairly equal in men and women. So that is something that I'm concerned about. Of course, the utility of valproate in treating all phases of bipolar disorder probably is also something that is going in its favor. And like I said, the narrow therapeutic range of lithium is probably something that scares us to a great extent and scares patients more. So if patients are given a choice and they're explained about the narrow therapeutic range of lithium, they are less likely to choose lithium. So I think all these factors could be adding to valproate getting prescribed a little more than lithium across the country.
Thank you, Dr. Muralidharan. This discussion could go on and on, but because of the paucity of the time, I think we limit it here. And thank you so much for such an elaborate and the wonderful presentation. Thank you.
Thank you so much, sir, and thank you to the organizing committee for having me on this program.
Thank you, Dr. Asad. Thank you, Dr. Muralidharan. Now we'll go on to the next session. Our next session is on adult ADHD with focus on gender. Our speaker for this session is Dr. Zia Nadine. For this, we will have two chairpersons. First will be Dr. Nitin Gupta and second will be Dr. Karsi Chawda. I'll introduce Dr. Nitin Gupta. So since 2019 October onwards, in full-time practice, specialized in psychotherapy, adolescent mental health, clinical psychopharmacology, and risk assessment. In 2012 to 2019, worked as professor of psychiatry in Government Medical College and Hospital, Chandigarh. Earlier, he has worked as a consultant psychiatrist in the South Staffordshire and Shropshire Healthcare NHS Foundation Trust, Stafford, England in general adult psychiatry with additional lead responsibility for the local licensed services for over 8 years. Areas of special interest are psychotherapy, community and rehabilitation psychiatry, adolescent psychiatry, licensed psychiatry, clinical psychopharmacology, and risk management. He has won awards. He was awarded the Kataria Memorial Gold Medal of PGIBR for the best postgraduate student in the institute for year 1996-97. In India, he is the recipient of over 20 national or zonal conference awards. of IASP, IPS, ICMH, IPS, NZ, etc. In UK, he was the recipient of 5 clinical excellence awards during my tenure in the NHS. Welcome, sir. Our next chairperson is Dr. Karsi Chawda. He is a consultant at PD Hinduja National Hinduja Healthcare and the SRHN Reliance Foundation Hospitals. Had been chairperson of the task force of the Indian Psychiatry Society dealing with school psychiatry and counseling. Was panel member of the task force of the IPS dealing with ethical boundaries between client and doctor. This has now been taken up by the IMC as a guideline across Indian health services. Was chairperson of the task force of the IPS dealing with the LGBTQ community. We managed to issue a position statement that was quoted in the landmark judgment by the 2 of the 5 learned judges when they repealed section 377. Was panel member of the IPS task force that laid down clinical guidelines for the treatment of autism spectrum disorder. Had been part of the first panel of the Maharashtra government that had laid down consensus for learning disability in concessions for learning disabilities in Mumbai. Written a chapter in 4 books 2 years ago. Was awarded the prestigious Dr. S.N. Lula Foundation Award. I will request Dr. Nitin Gupta to introduce the speaker and Dr. Karsi Chawda to introduce the topic.
Thank you very much. Good afternoon, everybody, and to Dr. Karsi Chawda, my co-chairperson. And also thank you to the organizers of the conference for having me as the chairperson today. It's a pleasure to introduce Dr. Zia Nadeem, who's the speaker for this session. He's a consultant psychiatrist at Radiant Hospital, Institute of Mental Health, Addiction and Rehabilitation. Dr. Nadeem has trained in psychiatry at the Royal Edinburgh Hospital and also obtained his membership of the Royal College of Psychiatrists from UK and CCT from GMC UK. He's carried out original research in the field of schizophrenia and worked as an honorary lecturer in clinical psychiatry at the Division of Psychiatry, University of Edinburgh, and has also given a lot of lectures and conducted workshops in various countries across UK, India, and Kuwait on various psychiatric topics and has got several publications to his credit. And we look forward to hearing him regarding this very important topic of adult ADHD, for which I'll request Dr. Karsi Chawda to introduce it, please. Over to Dr. Karsi Chawda, please.
Thank you. Good evening, all, and warm welcome to Dr. Zia. Today, in our own private practice, we have a lot of people coming in and saying, Doc, I have attention deficit disorder. And very often we evaluate them and we either find that they do have it or they don't have it. Very often it's gender-based. We see a lot of stuff happening, which kind of intrigues us, which makes us wonder just how much is actually based on Dr. Google and what our patients do and how much is actually based on reality. We look forward to learning about some guidelines related to this. Dr. Zia, over to you.
Hi there. First of all, thank you very much for inviting me to speak on this important topic. I would like to share my screen first and then start the presentation. Right. So, first of all, being the last speaker of the day, I think has got a couple of advantages as well as disadvantages. The biggest disadvantage has been, after listening to psychiatric luminaries and experts talking so eloquently on various topics, because I'm in the UK just now, so I joined a little bit late, just in time for the very erudite presidential lecture, and then then onwards to the transcranial magnetic stimulation, to bipolar disorder, etc. So it has been a big learning curve for me as well. So that's the biggest disadvantage that I'm starting with. The other disadvantage is that I'm speaking as a clinician, whereas all morning I have heard of lectures from researchers of top notch from India. The advantage, of course, is that people will be eager to go home by now. So I can say anything and hopefully get away with it. A slight correction to the first, to the introduction by Dr. Gupta. I'm not currently working at the Radiant Institute of Psychiatry. That was pre-COVID. I'm now working as a consultant psychiatrist in Scotland. So we are going to talk about the ADHD in adults with a focus on gender. And hopefully by the end of the lecture, you will realize why there's so much focus on gender nowadays in ADHD. Although many of us think that the concept of ADHD as defined in DSM is relatively new. And Dr. Chawla has already mentioned that people are coming with self-diagnosis and searching Google and TikTok videos and whatnot and talking about having ADHD. So the concept, although it's relatively new, but the analysis of historical literature suggests to us that the children presenting with similar symptoms have previously been described by several authors during the last 200 years. First example of a disorder that appears to be very close to the earlier descriptions of ADHD was given by Sir Alexander Crichton in 1798. Now, he was a Scottish physician who was born in Edinburgh, the same city that I'm in now, in 1763. And I have had the honor of working in a ward in Royal Edinburgh Hospital named after him as the Crichton Ward. So what he said at that time in 1798 was that when any object of external sense or of thought occupies the mind in such a degree that a person does not receive a clear perception from any other one. And then he also clarified that the distraction of attention does not necessarily have to be pathological. It could be a mental stimulus, it could be volition or education, which can have a great impact on healthy attention. Remember that for 1798, he was talking about ADHD in this kind of a description. Moving on, we see in 1844 that it was the German physician Henrik Hoffmann who created an illustrated children's storybook called Fidgety Phil. Now, fidgety Phil is a word, Dr. Gupta may be aware, that it is still used in the UK as a popular allegory for children with ADHD. Now, ADHD was first mentioned again in 1902. Again, another British pediatrician, Sir George Frederick Still, and I'm sure, still remember the description of the Still's disease, described an abnormal defect of moral control in children. It was then in 1932 that the German physicians Franz Kramer and Hans Pollnau reported what later on was adapted by DSM-3 as the hyperkinetic disorder in children. So what they talked about was a hyperkinetic disease of infancy. And the most characteristic symptom was the motor restlessness. Now, we all know what is ADHD. I don't want to go into detail, but just want to highlight that the three clusters, the three important clusters, the inattention, the impulsivity, and hyperactivity, and what happens to it. Now, I'm speaking at a biological psychiatry conference, and hence it is important that I also show that ADHD does have some biological correlates. People have talked about the CSTC loop or the pathway, the individual symptom domains correlating with corticostriatothalamocortical loops involving different parts of the prefrontal cortex. Now, again, you can actually divide and match the individual domains of the ADHD symptoms to the different parts of the brain. For instance, the sustained attention, which could be matched with problems in the dorsolateral prefrontal cortex. Now, People, I'm aware that a lot of you may have already seen adult ADHD in your practice, would come to learn about something like hyper-focusing. It is a common thing that some adults describe, that they can hyper-focus at the cost of other things. And that is selective attention that comes, where the anterior cingulate cortex. And of course, the hyperactivity, which is from the prefrontal motor cortex, impulsivity from the orbitofrontal cortex. Again, we heard an excellent presidential address by Dr. Mittal on neuroplasticity before lunch. And I want to mention that it is generally accepted that ADHD results from neurofibrillary dysplasia or atypical neuronal development. And of course, that the comorbid conditions have also similar correlates in nearby prefrontal and limbic CSTC loops. So we have to also talk about a genetic link, as is shown, by various research, and despite this research being quite old, but it is quite a well-cited research paper that talks about a 9-fold increase risk of ADHD in siblings of ADHD probands as compared with control siblings. Then another research on genetics talks about the heritability, the mean heritability picked up from various twin studies, which puts the heritability roughly around 70%. Now, when heredity is not a factor, what causes ADHD? Or what is thought to cause ADHD is difficult pregnancy, prenatal exposure to ethyl alcohol and tobacco, premature delivery. We all know about low birth weight problems and high lead levels, injury to prefrontal regions. And again, some of you might remember that there was a big controversy a few years ago about the triple vaccination or the MMR vaccination and its association with ASD, but not ADHD. So the commonest myth that we hear, and something, that general adult, psychiatrists have to grapple with, is the common myth that children with ADHD grow out of it. And this is something that I want to explain, that is a real myth. Various studies have put a figure between 50 to 65% of children diagnosed continue having symptoms into adulthood. Of course, these figures have attracted their own critique, and critiques talking about that these studies were mostly retrospective and not prospective. So it's difficult as to how this figure was arrived at. But whatever it is, the fact remains that in private practice or in, wherever you're practicing, you will come across people, what we call them as ADHD graduates. Because, in the NHS in the UK, there are people looking after children and adolescents separately. So they pass them on to us the moment they cross 18 years of age. So we call them as ADHD graduates. And every week we receive 2 or 3 such referrals where people have been referred to us for the adult psychiatry or us running the neurodevelopmental disorders clinic in the UK to take over their case. Now, few people are aware of serious consequences of adult ADHD, and I'll tell you about the consequences a little later in a couple of slides later. But the prevalence, again, of adult attention deficit hyperactivity disorder, again, between 1 to 2.1%. Some people have called ADHD as a hidden disorder, and the reason being that these symptoms are mostly obscured by problems in relationship, problems with organization. Now, if you look at those problems in relationships and problems in problems in relationship, problems in organization, employment, what people do is put them under adjustment difficulties or adjustment problems, problems with mood disorders, problems with substance abuse, addiction disorders. And that's how that ADHD sometimes still remains hidden in certain adults. Now, what happens? The consequences of untreated ADHD, more than twice as likely to have been arrested, 78% more likely to be addicted to tobacco and alcohol now, twice as likely to have been divorced, more than twice as likely to have dropped out of high school. Now, because these studies were mostly carried out in the West, where dropping out of high school is a big life event. It doesn't normally happen, and when it happens, people have to sit up and take notice of why it has happened. And people with untreated ADHD, they found that it is actually more than twice as likely to have dropped out of high school, twice as likely to have held 6 or more jobs in the past 10 years. Now, this is another very common thing, another common theme you come across when you're talking to people with adult ADHD. And in Hyderabadi lingo, people like these, when they shift from one job to another, they say, kahin tikke nahi rehta. So remember this, that kahin tikke kaam nahi karna, the ability not to stick to one place and one job for a long time is a red signal there. Recognizing adult ADHD becomes difficult because it's not the typical picture that you see in children. Again, in another slide, I'll show you how sometimes it can be different. But what we come across is the constant disorganization, poor time management. When I do sometimes now ADHD assessments on Zoom, I tell my patients to move their computer or laptop around their room and show me how disorganized their rooms, their table, etc. is. Failure to plan ahead, frequent forgetfulness, losing things, continual problems, starting or finishing projects. This is very important. They say we start one project, leave it, and then start another one, leave it, and then go on to another one. Impulsive decision making, saying things without thinking, and ongoing problems, concentrating and paying attention. Restlessness, fidgetiness, anger control, difficulty keeping, all these are signs and symptoms that you very commonly find in adult ADHD. Now, when you compare the ADHD with children and adults, more or less it's the same, but at the same time, it's quite different as well. Adult ADHD is more difficult to recognize, which is why many adults remain undiagnosed. Now, the core symptoms remain the same, but the symptoms change. How they change, for instance, here on the left-hand side, it is the children. So hyperactivity, they cannot sit still and they are always on the go. Among adults, it's the can't staying focused on one thing. Children climbing or running at all inappropriate times. Adult is fidgety or impatient all the time. I mean, I'm hardly yet to see an adult running around his house, jumping on the sofa table, but then they're constantly fidgety. You will see in your chair, sitting in your office, that the other person, that the patient is constantly fidgety, shifting posture, moving from one position to another, constantly touching their head, playing with something in their hands, etc. Children, physical impulsivity, they do things that result in injuries. There is a verbal impulsivity in adults. People say the wrong thing or speak out of turn. Sometimes when you hear from all these political statements from children and then from politicians, and then they come back, oh, I was quoted wrong. Sometimes I think whether it is the verbal impulsivity, whether these people also have ADHD that makes them say the wrong things at the wrong time. That is an important consideration. Children, they have problems waiting one's turn, like, you know, in school games which have various competitions, or people have to go turn by turn. ADHD children will almost always have difficulty waiting in the queue. Adults, they interrupt others excessively. If it is an open desk office, they move on from one desk to another, talking to another to another person and disturbing him. Similarly, you know, children, they can't pay close attention in class. Adults will have difficulty concentrating at work. Now, coming to the main focus of the topic today is how different, once we have realized that, you know, ADHD is definitely found not only in children, but also in adults. But among adults now, what is happening is, what is being realized and recognized is that it is usually, again, just like children, prevalence and you know, rates, they have said 2:1. Similarly, people are finding that in adult ADHD also, there's a wide variation. Any practice, any statistics you take, you will find more males than females. And until recently, it was considered as a male dominant disorder. But now studies after studies showing that females with ADHD struggle greatly compared with females without ADHD, whether it is academic, whether it is cognitive, whether it is psychosocial or psychiatric problems. And those rates are actually comparable as males with ADHD. But it also affects the females in different ways. In a little while, I'll tell you how it is different. Despite some of the symptoms being similar, there are still lots of differences in prevalence, in presentation, in symptom expression, in trajectory and the course of the illness and impairment. So again, it is recognized ADHD in girls is under-recognized, understudied, and underdiagnosed, and there can be no doubt about that. Predominantly inattentive symptoms, internalizing symptoms, comorbidities, females' own masking tendencies, and of course, the hormonal mediations combined to create a very complex and unfamiliar presentations. The other big problem is girls face multiple obstacles to diagnosis. I'm sure, you know, you would have heard many times that, you know, parents say, oh, this is not a problem that girls have. Since you're doing well at school, since you're managing well in school and you're able to do your work, you do not have ADHD. That is the very clear picture of girls being overlooked, misdiagnosed, or diagnosed late. What happens? Why does that happen? Whether it is teachers or family members, if the girls are restless or have ADHD problems, they are called spacey, they are called forgetful, they are called chatty, and that's it. But when an adult female seeks help for her symptoms, ultimately what happens is the diagnosis is made of depression or anxiety disorder. So in our clinic, what we see when we are seeing a female for the first time for ADHD, they have been on a trial of 2-3 antidepressants and anti-anxiety medications, has had CBT, has had so many things for anxiety, and that has remained unabated. That's when they come to the ADHD clinic. And then the culture, whether it is Western culture or Indian culture, it is still expected that women will fill the caretaker role. And when the the problems with ADHD start, and the women are not able to fulfill this caretaker role. That is when the problems start. And this societal pressure greatly increases a woman's feeling of inadequacy as well. Difficulty again in diagnosing ADHD in females is because they are typically less disruptive, aggressive, impulsive, or hyperactive than boys. At the same time, they also have this tendency to mask their difficulties. But at the cost of not being assessed, they are not getting help. So what happens is undiagnosed adult females are at particularly high risk for depressive symptoms, escalating into major depressive disorder. Now, that can be associated and missed because of these problems. Earlier onset of depression, greater episode duration, because it's not hitting the right targets. You give antidepressants, you get anti-anxiety, but it is not hitting the right targets, not going to the right receptors, and hence there is a greater episode duration. And then, of course, more severe impairments, often accompanied by some manifestation of self-harm. They also develop, or sometimes we have found that there is a correlation with females of ADHD and autism. Lately, we are finding with them developing or showing signs of borderline personality disorder, or what we call here in the UK as emotionally unstable personality disorder, with intense symptoms which can actually hide the ADHD symptoms. Now, another problem that gets added on is that there is evidence that ADHD symptom severity varies in response to hormonal fluctuations. Girls enjoy enhanced cognition, mood, motivation, memory, when estrogen and corresponding dopamine levels are high, as against to low estrogen levels when they are likely to experience exacerbated ADHD symptoms and comorbid internalizing symptoms. And this cumulative symptom burden can destabilize even the highest functioning girls. So sometimes you see that they're doing well reasonably for 20 days or 25 days in a month, but a week to 10 days, it becomes very difficult for them. Whether it is work, whether it is other household chores, etc., it all becomes a burden. And until and unless it is recognized as ADHD and proper treatment started, the cycle continues. Now, compared with the neurotypical peers, girls with ADHD, higher risk of developing eating disorder for various reasons, because sometimes they tend to forget to eat in time, or if they are at university or living an independent life, their life is so chaotic that they do not have a proper plan to make proper meals in time, and etc., along with sleep disorders and addictions, risk of unplanned pregnancies, and they also experience lots of somatic discomforts like headaches and other body pains, also like migraines and asthma, more likely to have tactile defensiveness, more likely to take prescription medications for anxiety. As I said, several times we have seen people coming to ADHD clinic already having been diagnosed with depression and already taking 2-3 antidepressants, or having tried several antidepressants in the past, and more likely to underachieve academically and or vocationally. And again, what we are finding in our practice, both in my NHS practice and in my limited private practice, is that as soon as they join the new university, because until university, there is still a semblance of orderliness in the house. But the moment they leave the house to join the university, it's like all hell breaks loose, and they just cannot manage their life without continuous input, because there's nobody to give that kind of input at the university. Now, some of the symptoms, which are again not very much different from the male adult ADHD, is difficulty concentrating, struggling to stay organized, being very forgetful. So many things they come back and say about making mistakes during food preparation, or having forgotten their phone and left the phone several times, forgotten their keys and having locked themselves out of their flat. Problems listening and paying attention to details. The problem was also highlighted during the COVID pandemic, when university students were required to be doing their courses from home. They were just not able to pay attention to listening to recorded lectures or lectures via the Zooms, and they were zoning out. They were getting distracted. They have showed me books with doodles, full of doodlings and drawings in their books, because they cannot maintain their focus. Indecisiveness, difficulty relaxing, relationship difficulties, and becoming easily overwhelmed and emotional. I'll talk about the emotional price sometimes they pay a little later again. And social gatherings, problems with self-esteem, and of course, various problems of mental health conditions, because they try to mask it as depression, anxiety, or stress. Now, what happens with ADHD and emotions? The volatile and sometimes destructive emotions associated with ADHD, especially among females, can manifest as frustration, sensitivity, or a tendency to feeling sad. Now, this is being referred to as something like rejection sensitivity. Now, rejection sensitivity has already been mentioned with depression and associated with depression, anxiety, and borderline personality disorders. But nowadays, it is being increasingly recognized that the rejection sensitivity is much more prominent and much more exacerbated in females who have ADHD. So what is this rejection sensitivity dysphoria? It is not a diagnostic criteria. It is not, a DSM criteria. I think it is just a symptom or a cluster of emotional problems that people. Now, when you ask an adult ADHD person, have you always been more sensitive than others to rejection or criticism or being teased, or your own perception that you have failed or fallen short? The answer inevitably will always be a big yes. So what that leads to, the rejection sensitivity dysphoria, leads to disapproval from others, or at least it's not exactly the disapproval from others, it is the perceived disapproval from others. The ADHD adults, they think that there is criticism and then withdrawal of love and respect, and they find it just as devastating as the real thing happening, although the real thing is not happening. It is just the perception. Then they're always on an edge. They can never relax. I can just sit there and watch a TV program with the rest of the family. They cannot go out for a family meal where they can sit and relax for an hour or 90 minutes of a relaxed meal. And then if the emotional pain is internalized, then it leads to periods of sadness and loss of self-esteem, etc. again. So how does the rejection sensitivity or the overload of the emotions in ADHD, especially in females, affects behavior? What happens is that they find the pain of perceived failure so bad that they refuse to try anything unless they can be assured of a quick, complete, and easy success. Until and unless they are assured of that, they don't want to try anything, which means, again, that they are limited in the avenues available for them to explore. How does it affect personality? Now, what happens is that they become people pleasers, because they are again perceiving the fact that they are being discriminated against for various reasons. And hence they try to become people pleasers, which of course takes its own toll, because you're constantly trying to please people. You cannot please everyone all the time, but then that takes a toll on one's health. How does it affect relationships? Now, because they perceive that the other person is misunderstanding them or mistreating them, they kind of get into that cycle that they have to remind the other person that they are worthless, they're stupid, and they're harmful, and they're always disturbing other people. Now, this affects relationships. I mean, when you see couples in the clinic, the partner invariably says that their relationship is almost at a breaking point because the person with ADHD is always misinterpreting things and emotions. And then females develop this imposter syndrome that they think that, they only know the extent of their difficulties and their failure, but they are still performing well, because if you look at an average ADHD person, they're actually quite intelligent. So somehow they manage to get their things done, but then because of the fact that they are always under this fear, they develop that people will come to know that I'm an imposter, I'm showing off things, although I'm not actually capable of doing that. Now, I'm coming to the end of it. So I'll just quickly summarize that the concept of ADHD is not new at all. And then the corticostrial thalamocortical circuit has been associated with ADHD where prefrontal hypofunction. 50 to 65% of children diagnosed continue having symptoms into adulthood. And of course, there are recognized difficulties in diagnosing adult ADHD, especially in females. And females with ADHD struggle greatly compared with females without ADHD. And there are other psychiatric problems, earlier onset and greater episode duration of the psychiatric problems like anxiety and depression, and of course, severe impairment. And there is also evidence that ADHD symptom severity varies in response to hormonal fluctuations. And then the volatile emotions can lead to another symptom of ADHD as the rejection sensitivity dysphoria. So these are some of the references, and I would like to thank everyone for a patient hearing. I hope it has been of some use and help to people. Thank you.
Nitin, you want to take over?
I think it's been a very interesting and wonderful presentation, actually, shedding light on the gender differences and regarding how female adult ADHD tends to present and the difficulties which one can experience in being able to pick up such individuals. Because as we know that we tend to encounter males much more often. I do recall when I was back in the UK, and I think even now when Dr. Kirsi Chavda was mentioning about adult ADHD presenting, it's predominantly males who come forward, and female ADHD is not, adult ADHD is not that common. Females don't tend to approach. I mean, that's my experience, and what I remember from my experience in the UK also. Dr. Chavda can supplement that from his experience, that females generally don't approach that easily, and it is not easy also that much to engage with them as it is with the male ADHD counterparts. So I think it's been very useful in that way to hear about the clinical experience of Dr. Zia Nadeem and also from the literature which he has provided. It's in that way. Adult ADHD is not an easy population to deal with because of the multiple comorbidities which are associated with them, and these additional different kind of comorbidities which the female adult ADHD is present with make them probably a more unique and difficult population to not only diagnose but also to manage. So I think it's quite a new learning experience. Because we have shortage of time, I'll hand over to Dr. Chawda to give his comments and probably have we can take up one or maximum two questions. Over to Dr. Chawda, please.
Okay. Dr. Zia, I want to ask you a question myself. Supposing a first-time person comes up to you, first-time lady comes up to you, and you evaluate her, and you find that she has severe anxiety. She also has attention. You feel she also has attention deficit disorder. Would you treat both? Would you treat the anxiety first? Would you treat the attention deficit first?
Oh, that's a loaded question, Dr.
Yes.
Chawda. Yes, it is a clinical conundrum, to be honest. And I think we do grapple with these situations almost on a daily basis. Because there is already a back press to the use of stimulants or non-stimulants in the use of management of ADHD, if balancing the things that we find that it is the anxiety symptoms, I think again we take the unfortunate same route as other people have taken before. Although mentioning that, yes, we do recognize your ADHD symptoms, but because the predominant presentation is one of anxiety just now, I do understand that if we later on treat the ADHD, the anxiety symptoms may go away, because one of the other things, again, as you know, you will find in adult ADHD is a lot of anxiety and mood instability as well. So if it is predominantly the anxiety which is a problem, I do suggest that they have non-pharmacological treatment for anxiety like CBT or occupational therapy and anxiety management first, but at the same time also consider, having diagnosed that with ADHD, to consider something like a non-stimulant like atomoxetine. As you know, atomoxetine is an SNRI as such. And that would help with the anxiety as well. Because again, the problem with the stimulants is that there is always a tendency that whether it is lisdexamfetamine or methylphenidate, it can cause anxiety or it can increase or exacerbate the anxiety. So explaining that, nowadays, because we have the added difficulty of dealing with the patient expectation and patient choice, we explain everything and then choose something of a middle path rather than reaching for the prescription pad and writing out a stimulant again. This is what I would do. And I have noted that non-stimulants, people on non-stimulants do respond to anxiety very well as well. Bupropion is another molecule that has been used for anxiety or mood, motivation problems in people with ADHD. Thank you.
Thank you. Alkesh, I can't see anybody putting up their hands for a question. Can you spot anybody?
No, sir. There is no question in chat also.
There is a question. Could you just...
No, sir. There's no question. There is no.
Oh, there's no question. Okay. All right. Okay, if there's nobody else, we've already overshot our time by about, the time of the conference by about 45 minutes. So I'd like to say a very, very big thank you to Dr. Zia for an extremely educative, yet simple explanation, which makes all the difference in the world rather than going into paroxysms of intricate stuff which may not really have too much of a practical use. Thank you so much, Zia. Dr. Nitin, would you like to say something also?
That's fine. Thank you
That's
very
fine.
much.
Okay. Thank you,
Thank you
Ankesh.
very much. It was a pleasure talking to the august audience here. Thank you for chairing the session, sir.
Thank you.
Both of you.
Thank you, Dr.
Thank you.
Kasi. Thank you, Dr. Kasi. Thank you, Dr. Zia Nadeem, and thank you, Dr. Nitin Gupta. So I'll hand over the session to Dr. Rakshita, and Madam will give the ending comments.
Thank you so much for thank you so much, everyone. The last session was indeed a very good place to stop because that was so much more clinical and, like Dr. Kasi Chavda said, so relevant and so interesting in its simplistic way. So I think that's a good note to end for the day. Of course, my job as the General Secretary does not end here. I hope that all our members, IABP members, join us for the AGPM at 7 p.m. That's again online. The link has been sent to everybody. And with that, I also request everyone to join us tomorrow at 9 a.m. tomorrow morning in Hall B for the free paper presentations. Encourage our young colleagues who want to present their original work. And 10 o'clock again in Hall A with a lot of symposias and debates and Ask the Expert YP events. So we have another full day of academics and fun to be had tomorrow. Because well, when you learn, it's always fun, isn't it? So thank you so much. With that, I bid you good evening. Have a good day, and I will see you guys tomorrow. Thank you.
Thank you.
Thank you.